understand anatomy and I remember anatomy, then as I go through an evaluation, then I know what I'm looking for, and then I found it, and then I can move on to the next step. So that's really our thought process. So I always look, because look is safe. What would I be looking for? Any obvious anything. So asymmetry, signs of swelling, signs of trauma, signs of bruising, maybe a big giant open wound. If I see blood gushing, that's kind of like, oh, hey, that's obvious. Got that. Usually, though, with the musculoskeletal complaint, they don't come in that obvious. But it's nice to know. I mean, if the kneecap is not in the center of the knee, but sitting way over to the left, my MSK exam gets a little bit easier because I now have identified that is not in the right spot. It must be dislocated. Okay, so I always follow the same thing. So what it is really nice to do in terms of examination is to have a strategy of moving forward, to have a pattern that you follow every single time. So no matter if I'm looking at the back or the foot, I have a strategy and I am going to follow a pattern of examination every single time. And even if I walk in and a patient's sitting in front of me and I totally blank out as to what I'm supposed to be doing, I can recall my pattern and walk my way through it. Okay, so that's kind of the goal. And the pattern is always start with observation because it's safe. And then from my observation, I can decide what I need to do next. Because there may be a point in the exam where I get started and there are enough answers present that I don't need more information, or there are enough answers present that tell me this is serious, and I get to a point where I don't want to create more trauma than exists, so I make my decision. Does that make sense? Okay. So we will always look, and then we will always ask them to move. So range of motion, ROM, is bolded because I really can't do a musculoskeletal exam without seeing how they move and seeing if I can reproduce symptoms when they move, or I may be just seeing can they move, or did they tear or break something that is now preventing them from moving. So key steps are, can they move, are they willing to move, and then I'm going to ask them to move. If they can move, then I may want to stress it further and test their strength. So MMT is manual muscle testing, it is strength testing. But if they're not willing to move or they don't have the strength to do it, then I'm not going to add stress to that. And it'll make sense as we go through it. Okay, so the first part that we're going to look at is the low back. So we are on the MSK Neuro Back handout. Okay, so when a patient comes in and they are complaining of back pain, they may be complaining of back, buttock, and or leg pain. The one thing that I need to know is that if they complain of symptoms below the knee, it is more likely to have a nerve component. If the symptoms are above the knee, then it could be anything. So if they tell me they have back and leg pain, and that leg pain goes down to the foot, there are very few anatomical structures that connect one to the other than nerve. So if that's their chief complaint, in my head, I'm like, this could be nerve. If the symptoms don't go below the knee, I'm not as lucky. This could be anything. So I have to keep my mind open for anything. Okay, so we said we always start with looking, because that is our cardinal first step. so what position do you think we're going to ask them to look? We're going to look at them in sitting, lying down, standing, standing. So with spine, we are going to start with a postural assessment. We're going to look at them standing. And when someone is standing, do you mind standing up for me? When someone is standing, what do you think we're looking for?
Symmetry, like one shoulder.
All right, absolutely. So symmetry right to left. So let's look at him. What do you see? Okay, we see muscle. Very good. Muscle. All right. Okay, and let him chance it now. No, you're not done.
Oh, okay.
Muscle is good, but that doesn't mean we're finished. He's got muscle. All right, but we're not done because you can still have pain and have muscle. Okay, true. So we're going to turn. We're going to have you turn. Can you tell that one shoulder's higher than the other?
Oh, that side. Oh,
Okay, so I have a little asymmetry. Now, is that meaningful? Is it not? I don't know. It is pretty normal for someone to have one shoulder higher than the other because we often have one arm stronger than the other. We call it a dominant arm. So, I mean, we're looking for symmetry. We're looking for height, differences from right to left. But if I see something that's different, it doesn't necessarily mean it's pathological. But I can see that. Okay, so when I look this way, what am I looking for? Curvature. So what curvature do I expect here? A lordosis. And then what curvature do I expect here? Which he's kind of straight. But a kyphosis. And then what do I expect here? A lordosis. So I'm looking to see, do I have that smooth curvature, a cave, a convex, and a concave, or lordosis, kyphosis, lordosis curve. If I saw that this scapula was more posterior than this one, and he was kind of positioned like this, what would I think?
Scoliosis.
Scoliosis. So I'm looking for one, is there a smoothness and curve in the sagittal plane, lordosis, kyphosis, lordosis. And then I'm also looking for, do I see signs of a rotational or frontal plane, which means there may be something structurally wrong, which is scoliosis, sign of the spine. Okay, so I look. What else would I look at landmark-wise? What about here? What would I look for? Okay, so I want to look for height of the iliac crest. Well, let's see. Do his look symmetrical? They feel pretty symmetrical. What if the right one was higher? Okay, left leg might be shorter or right leg might be longer, but there's a leg length discrepancy. So I want to check for that because that could impact his spine if one leg is longer than the other. So I'm going to come in and just look. Are his iliac crests the same height on the right and left? I can also just look at his legs, which again we're going to see muscle, but that's good. But I can look at, does he have an extended knee? Does his knee line up with his ankle? Is he willing to put weight on both sides? If he's not, he's going to stand on one leg, then it tells me there may be a problem with the leg and he just doesn't want to put weight through it. What if he came in like this? What's he doing? Okay, he could be slouching. We call this side bent. So he's bent over to the right. If he's bent over to the right, he could be avoiding this position because it hurts to be here. So if he shifted one way or the other, we call this a lateral shift. So I see a sign of a lateral shift. That means that he may have a disc herniation. That's a kind of sign for that. He has a disc bulge, a disc herniation, and when he stands upright, it pinches it. So he wants to unload it. So he'll shift off to the side. So I might see a sign of scoliosis. Or I might see a sign of a lateral shift that is not scoliosis. Now I don't know until I do a little bit more which one that is. But I'm gonna look for alignment. Does he look symmetrical right and left? Are the shoulders the same height? Are the iliac crests the same height? Are the knee folds the same height? Is the knee pointing forward? Is he willing to put weight on both legs? Now you can see his feet. What do you see about his feet?
Toes are outward.
His toes are outward. So when we get to hip, we'll talk about that later. But his toes are turned out. So that tells me he prefers to externally rotate his hip for some reason. I just have to figure out why that is. Because typically in a normal standing, it's all right. You can sit down now if you want.
Okay. Yeah,
I'm gonna keep pointing stuff out. So I want to sit down. All right, so if the toes are turned out, that's not what I expect to find. So when I look at posture, I am comparing what I see to what I expect to find. And anything that is outside of what I expect to find, I make a note in my head because it's meaningful. It means something. I just have to figure out what does it mean. So I start with posture. Now there are some things that I'm really concerned about when a patient comes in, and we call these serious things. So if they come in with low back pain, I want to make sure they didn't break a bone, they don't have a fracture, that they don't have an infection, that they don't have a tumor, it's not cancer, that they don't have a medical emergency of an aortic aneurysm, or they don't have a compression that's so big in their lumbar spine that it is impacting the cauda equina, and they aren't necessarily presenting with something like RA or ankylosing spondylitis or something that's inflammatory, not mechanical low back pain. So the biggest and most common of those is a vertebral fracture. In their history, they would report a trauma that would make me think that. And if you have a fracture in your back, you are also not willing to move. So as we move on, they're going to have high pain and they're not going to be willing to move. So these are the things that we're trying to rule out. How would I think about infection?
Do we see signs of swelling or inflammation?
Okay, so I see acute signs of inflammation. The area is warm, it's red, it's super irritable and tender, and then they may have concordant signs with that. So they don't feel well, they feel sick, they have a fever. And so that's easier to pick out, but sometimes that discitis will show up and we just have to rule that in or rule that out. Fracture, there is usually a trauma, unless, who's at risk for fracture in the spine? Yeah, so osteoporosis. So medical history will tell you that. And oftentimes, where does the vertebrae fracture in osteoporosis? Yeah, the body. So their posture tends to be stooped or more kyphotic. So if we see that stooped posture and they're complaining of back pain, we put those things together and go, that could be a sign of something more serious. And I'm going to be cautious. I'm not going to start pushing on them if that's what I'm thinking in my head. Okay, so postural alignment, we're going to look and see, does anything match or is anything outside of what I would expect? And I'm going to notate that. Then the next thing that we do in a lumbar spine exam, after we look, in your notes it says we can also palpate. So I can touch, and I had to do that. You saw that I had to touch to find the iliac crest. So what would you palpate as you're examining standing posture?
Spine.
Okay, so I can palpate. So as I rubbed up and down his back, I was feeling the curvature, and I can palpate spinous processes. And if there is a fracture, it'll be really hypersensitive or hyperalgesic in that area, and I will find it really quick. So I can use palpation to just look for areas of hyperirritability, which will tell me where I need to focus my attention. If something is happening in the spine, there is a connection between the capsule of the joint and the back extensor muscles. So I will often see spasming or increased tone or tension in spinal musculature, and I can palpate for that too. So you can rub your hands kind of up and down. So in the middle is the spinous processes. On the sides are what we call the erector spinae. And if I feel increased tone or tension in those muscles, it's confirming to me something's going on in this area. So that's a positive support for, yep, this is coming from their back. Now, it doesn't tell me exactly what's coming from their back because they share innervation. So it could be joint, it could be disc, it could be muscle, it could be all that, but it still confirms something's coming from their back. So I palpate for that. On the list, is there anything else you would palpate for? So muscle, processes, SI joint. How am I going to palpate the SI joint? Where do I find it? Okay, before I ask him to move, there is a bump right here. Does anybody remember what this bump is called? You can find your own. Find your own iliac crest for a second. And then slide your fingers down and you're going to hit bumps. That bump is the PSIS, or posterior superior iliac spine. It's just inside that bump where you're going to find the sacrum. Can you feel that? So feel here, PSIS. Come just medial to PSIS and you're going to hit sacrum. That's where your SI joint is. So I can palpate iliac crest. I can go to PSIS. I can go inside and palpate the sacrum. I can then come in the midline and palpate the spinous processes. And I'm looking for, when I touch this, does it hurt? Does it hurt to touch the iliac crest? Does it hurt to touch the PSIS? Does it hurt to come in and touch the sacrum? And then does it hurt to touch the spinous processes? If I can reproduce their pain by touching those structures, then it's letting me know something in that area is contributing to their pain symptom. Okay, so I can palpate those. Then the next thing that I'm going to ask them to do after I look and after I touch is I'm going to ask them to move. So there are 3 planes of motion, so we ask them to move in each of those. So the first is flexion and extension. And that's kind of our first. So we'll say, can you bend forward like you're going to touch your toes? So I am watching their willingness to flex forward. And I want to see, are they willing to do it? How far did they go? Do they move in their spine at all, or is it all in their hip? And does this change their symptom? Because when I bend forward, I'm putting a lot of stress on the posterior structures. And it's pulling, so there's a lot of pulling. I will also watch to see if their knees bend when they come forward, because they may be avoiding tension on dura or neural structures if they do. Or their hamstrings are really tight. That's okay, because that might be you. Your hamstrings are just really tight. Okay, so I asked them to bend forward. How far did they go? How far should they go? Okay, as far as they're willing, but what's normal? I expect them to be able to okay, so I expect them to get past their knees and get close to their toes. We'll see what you do. But they may not get all the way to their toes. Okay, but I do expect them to be able to flex enough where they get to or past their knees. So if they aren't willing to go that far, that is outside of what I expect. That's important to know. And then I want to know, why are you not willing? Why is that all you've got? Does that hurt? Does that increase your pain? And if they say yes, I say, where? And they'll point. They'll let me know where they feel it. And if it increases their pain all the way down into their leg, what am I thinking? Past the knee? Nerve. So I'm thinking that. Especially if they look down and it gets worse. So if they move their head or tuck their chin and it gets worse, I'm like, oh, yeah, that makes sense because I'm pulling on it. Okay, so if they move forward, then they need to move backwards. So when they move backwards, I can ask them to support themselves on their hips and then just arch backwards. Okay, so when I do that, some patients will do what I'm about to do. You ready? I'm going to cheat. Where did I move? My knees. Which, whoa, I can look up at that ceiling and not move my spine at all. Right? I totally cheated. But if I ask them to arch their back backwards, I can see how willing are they to go. How much do I expect? If they're a gymnast, they're going to be able to put their hands on the ground back there, right? If they're 15, they're going to be able to they're going to have a lot of extension. The older we get, the stiffer we get, that's normal, it's not bad, the less extension I'm going to expect. So the age of the patient matters for this one. The older they are, the less I expect to see. But I should see a good, like they should be able to increase their lordotic curve a little bit. I should see it curve a little bit more. And if they aren't willing to do that or they won't bend there, they have a loss of extension. And that means something to me. Because with extension, I'm now compressing the posterior structures. And then I want to know, does this change your symptom at all? Does it make it better or does it make it worse? If it makes it better, then shortening structures in the back feels good. If it makes it worse, compressing structures in the back is the problem. So that helps me just think about it. So touch your toes, arch backwards. Okay, then they have to side bend. So they have to bend side to side. What am I looking for here? What do I expect? What did you see me do? All right, so my hand again was touching close to my knee, so I had enough motion to be able to get to my knee. And then you should see opening on this side and shortening on that side. So we can kind of look and see, does the rib move away from the pelvis? And does the rib move away from the pelvis the same on the right as it does on the left? What am I looking for when I test side to side? Symmetry. So if it's not the same, that's important. And then, does it change your pain at all? Does it make it better? Does it make it worse? Anytime I change the symptom, I'm confirming I'm in the right spot. Even if I'm making it better, I'm confirming I'm in the right spot because I modified it with movement. Okay, so flex, extend, side bend, and then the last one is twist. So I'm going to ask them to rotate. I'm going to ask them to turn and look at the wall behind them. Now patients will do whatever you ask them to do, but they may not do what you're asking them to do, right? So extension was this, rotation could be this. I can look at the back wall. Sure, I can do that. Okay, there was no spine rotation or twisting whatsoever. So you may have to say, okay, that was a really good effort. I applaud it, awesome. But now I want you to keep your hips forward and try to look over your shoulder. Or you can hold their hips and have them look. Rotation, twisting, puts more stress on the joints. Bending puts more stress on the disc. So if they are not willing to turn or turning hurts the most, I'm confirming something's happening in the back. And it's the joint. So I can kind of think about those things.
I was going to say, what about anytime you hear popping or cracking or what would you say?
So noise is always interesting. Some of you will do this and you pop your back on purpose. That noise, that pop is a pressure change in the joint. It doesn't necessarily mean it's pathological or a problem unless that makes them hurt. So that's just a sign that there's a gas bubble inside the joint, or they made it.
It's not necessarily bad.
It's not necessarily bad. Sometimes noise is bad. here, we're like, oh, that's interesting, you have a noisy spine. But if it reproduced their pain, they popped and then it hurt, well, that means something.
Even if it's recurring without pain?
Well, so it's interesting to notate. So if it's rotation, if they say, oh, that's when it pops, and it happens every time I do it, that's worth writing down because it's pointing to the joint. If it doesn't hurt though, we're like, I'm looking for your pain and I didn't find it with that. So I'll keep looking. But good questions. Okay, so I asked them to move, I asked them to flex, I asked them to extend, I asked them to side bend, I asked them to rotate. And if it's coming from a structure, a musculoskeletal structure in the spine, that will typically do it. I will have increased their symptoms somehow. Now what I'm really concerned about though is the state of the nervous system. So I have to think about that in, okay, they told me their symptom is going below the knee, so I'm thinking nerve. It hurt when they went forward all the way down in the leg, I'm thinking nerve. Or it hurt when they went backwards all the way down into the leg, I'm thinking nerve. I need to make sure that the nerve is not compressed. Because a compressed nerve is more serious and warrants more intentional, immediate action than a non-compressed nerve. So we have 3 things we can do to test how irritable or how compressed the nerve is. What are those 3 things? What do you think before looking? How do we test the nervous system? Reflexes, sensation, one more. You got 2 out of 3 already. Motor units. So I can test the information coming into the spine through sensation. I can test the information coming in and quickly going out, spinal loop reflexes. And I can test the information going out, brain, spine, peripheral nerve, through motor unit testing. So if I have a patient who's coming in and they're complaining of back pain, that is coming, the spinal cord runs through there, the cauda equina is there, and then I have nerve roots that come out of there. So I have to do due diligence to make sure that the nervous system is not affected. Okay, so if you look at your list, we skipped neck for a second on purpose, we'll come back to that. And if you look at your list, we can look at the motor system and the coordination of the motor system by asking them to walk. So when I ask someone to walk, I can see one of 2 things. I can see a painful walk, which we call antalgic. And it basically looks like they're limping or not wanting to put weight on that side. Or I can see signs of motor weakness with the walk. So they're dragging their foot, they're not clearing their foot, they're not able to lift the leg. Have you seen differences between painful walk and then muscle weakness walk? So we're looking for that. When they walk in, if it doesn't look like what I'm expecting, why does it look different? Is it antalgic, it's painful? Or is there signs of motor weakness? Now we have some very important muscle units that we have to test because there are 2 nerve roots from the spine that are more likely to be pinched. L5 and S1. And the cool thing is that both of these roots contribute to the sciatic nerve and they have motor unit levels at the foot. So I can ask the patient to walk on their toes, and when they walk on their toes, they are in plantar flexion, so they're using gastroc soleus, which is testing which one of those nerve roots.
S1.
S1. And what reflex do I have to confirm that? Achilles. Isn't that cool? So I can test motor unit, I can test reflex, I'm testing S1. I can also test sensation at their foot, and I'm testing S1. Okay? Then I can ask them to walk on their heels. So I am making them use their dorsiflexors and their big toe extensors to get their foot off the ground. So what level am I testing? L5. Now I don't have a cute little reflex that I can tie to L5, but I do have that motor unit that I can test, and I have sensation that I can test. So I can have them walk on their toes, and really 5 to 10 steps is enough to show signs of weakness. So walk on your toes for about 10 feet, because that's about how big my room is, and that's what I've got. Walk on your heels for about 10 feet. And if I see that they are able to stay on their toes, their heel doesn't lower, or they're able to hold up their foot, it doesn't drop, then I have effectively kind of screened that motor unit. Now I'll come retest it, but that's a really quick screen that I could say I've screened S1, I've screened L5, and now we can move to the next thing.
Is that an error? Who walk for L4?
There are some textbooks that will say walking on your heels, there is an overflow of 4 to 5. Yeah, so there is overflow. It's not an exact science. This one only goes to this muscle. So there's a little bit of overlap, but it's pretty consistent. That if I walk on my heels, I'm testing some 4, but a whole lot of 5. Good question. Okay, so we've done that. We're almost through with our exam. Okay, all we have left is to be a little bit more thorough. So I get the patient to lie down. And the patient lies down. So I have looked at posture and spinal alignment. I've looked for my S-curves. I've looked for signs of scoliosis. I have asked them to move. So they have touched their toes. They have arched backwards. They've gone side to side and they've rotated. If it is truly low back pain, I have done something to their pain. Like that has gotten better or that has gotten worse. Most of the time it gets worse. It doesn't get better, because if that's all it took to get better, they would not be seeing us, right? Okay, and then I've screened motor units by asking them to walk on their toes. So I forgot to tell you one thing. You told me scoliosis, and that I could see that by seeing a deviation of their spine when they're standing. So it is not smooth and just lordosis, kyphosis, lordosis, but I see either the ribs are more posterior, the scapula is more posterior, or they seem to be slumped over to one side versus the other. How could I confirm with something I've already done that that is indeed scoliosis and it's impacting the structure of their spine? And I may need to confirm that by asking for imaging. Okay, I could palpate, so I'd palpate the spinous processes, and they don't feel like they're in the middle, which is another reason why I just find them, palpate them. And what else can I do?
Forward bend.
Forward bending, absolutely. So when they bend forward, they tighten all those posterior structures. So if it's not in line, I will see it. The ribs will be elevated on one side compared to the other, or the transverse processes, if it's not in the thoracic spine, will be rotated, and I will see it when they bend over. So if I see one side that's higher than the other when they bend over, then that points to scoliosis. So I've already kind of considered that in my exam. Okay, so if someone will come lay down, I'll talk about what we can do here, and then we're just going to do it. You ready? And you just get to lay on your back. Okay, so with her laying down, I have the opportunity to retest some of those motor units. And I can test this just to confirm, because let's say she didn't have the balance to walk on her toes or heels, and I'm not going to let her fall under my watch, because that is entirely too much paperwork. So if I don't feel comfortable asking her to walk on her toes or her heels, I can test that in a different way. So So I'm gonna have to have her slide off her shoe anyway to test for sensation and make sure that she can feel me in her dermatomes. And then I can come in and I can muscle test these motor units, these muscles, and just make sure she has the same strength on the involved side as she does on the uninvolved side. So to do that, I will test dorsiflexion, which is pulling the toes up. So I'm gonna have her pull her toes up and see, can she get to, I don't wanna do a straight leg raise on you, but can she get to at least a 90-degree angle here? So one, that'll just tell me she's too tight if she can't, and she needs to stretch. But if she can get to 90, I'm pretty happy, so I'm gonna ask her to hold that, and then don't let me push it down. So hold, and then I'm gonna push against her push, and I'm gonna see how strong she is. And if she can generate force, and I really can't push past her, she gets a good grade. She gets a 5. And so I'm looking for that. How much force can she generate on this side compared to that side? So that's dorsiflexion. That's a little bit of 4 and 5. Whole lot of 5. And then 5 by itself, a little bit more isolated 5, is extension of that big toe. So I'm gonna ask her to lift her big toe up towards her head. And then I'm gonna see that she can do it, and she just brings them all, which is fine. I let her bring them all. You can bring them all, it's fine. Bring all your toes. But I only wanna test the big one because I wanna test extensor hallucis, not the toe extensors, extensor digitorum. So I'm gonna say, hold that big toe, and I'm gonna push right on the nail of that big toe if it's not painful. If she's painful, I'm not gonna push there. And I'm gonna say, hold, don't let me push it down. So hold that up, hold that up, hold that up. And I'm gonna push. Now I'm pushing with my thumb, not my whole hand, right? Because it's one toe, not the whole foot. But I want to see how much strength can she get there. Is it as much as I expect? And I expect there to be some pretty good force. I mean, if we were to thumb-toe war, her toe should be my thumb. So I've got that. And if she can beat my thumb, she gets a 5. If my thumb wins, well, she doesn't get a 5. Okay. Then while she's here, I'm going to see, can you turn your foot out? Because eversion, turning the toes out, but not turning the hip. So just the foot. Can you turn your foot out towards my hand? And she does awesome. So that also is L5 nerve root. So I'm going to ask her to hold L5S1. Don't let me push in. And then I could also ask her to turn in. This will show up when we do ankle later. But I'm looking for signs of motor weakness. If she's strong, there's no motor weakness, there's no compression. Now I could also have her push down, push the gas pedal. That is testing the strength of the gastroc. Know that a grade 5 strength of the gastroc is to be able to come up and down on your toe 25 times. So my hand is not going to match her body weight 25 times. But if she can't come up and down on her toes, so you have to go up and down 25 times to get a 5. I'm not going to win. So she should beat me with this every time to get a good muscle grade. But if I win, that means there is definite weakness there. And that's S1. So I can test that. All right, so I'm ruling out the nerve. Sensation. You've also got your reflexes. Your patellar reflex for what unit? L3, L4, which we haven't talked a whole lot about. Why have we not talked a whole lot about that? What nerve is that? Sciatic nerve is the one that runs down the back. Common peroneal runs down the side, which is a branch of sciatic. L3, L4 is femoral nerve. And we haven't heard a whole lot about femoral nerve. And we haven't talked a whole lot about femoral nerve because entrapment of the femoral nerve is very rare. So if I see problems with L4 and I see quad weakness, I already am concerned. Like that's not a normal low back pain thing. So I have to think about it. If I see that, that's not a typical presentation, so I'm just gonna have to be more thorough with my exam. And we'll talk about that when we get to the knee, because we're testing that at the knee. Okay, so the last thing that I have is I wanna see if I can cause your nerve pain symptoms without moving your back. So that test is the straight leg raise. So to do that test, I am gonna hold the foot into dorsiflexion and lift the knee up and see if I cause any pain down the leg. So their pain down the leg. And if they have nerve pain, this test is usually positive before 60 degrees. What happened when I got her here? Her knee flexed, which means her hamstring is tight. We'll deal with that later, okay? But she had a change in response. So that tells me either she really doesn't like tension, but it's not her pain. So her nerves are like, yeah, that's enough. I'm taking tension off. But a positive is I reproduce her pain. So I said I dorsiflexed her foot to make this happen. So dorsiflexion puts more stretch on the nerve. So if I forgot to dorsiflex her foot when I was lifting up, well, I could add it here. So does this make it worse? And if she said yes, that means nerve. And then I could say, okay, well, what if we point the toe? If that makes it better, that also means the pain was coming from the nerve. So the straight leg raise is passive. I lift it up. I see if I reproduce any kind of pain with this. I want to know where it's at. If it's nerve, it is usually down the leg, below the knee. And dorsiflexion will make it worse. And plantar flexion will make it better. That's a positive straight leg raise. Okay, you ready to try them? Okay, let's see. So we're going to go through it together so I can talk you through it, but I want you to think about all the things you're looking for. So where do we start? Observation and posture. So you got to stand up and you got to look. Worst case scenario, in a patient who is not willing to do that, then you have to raise the shirt so that you can see the skin. Okay, so we're simulating for time purposes, but let's look at alignment. So look at shoulder height, look at scapular position, look at hip height, look at alignment of the knee, look at your partner, pick a partner.
You look at me and I'll look at
It's not what you expect to find. I mean, because we're real people and we're not always perfect at it. So we can talk about it. So palpate, see what you expect to find. Okay, so let's just talk about something that's different, because we got somebody who works out over here. Okay? We've got this beautiful, we're palpating spinous process and we're like, whoa, what are those? Well, that is muscle. Look, we got two muscle people in here. Yeah. Okay, so but is this, so I have to decide, am I worried about this? Well, she has one on the right and she has one on the left. It's not painful. I can move it. It's exactly where erector spinae is supposed to be. It's muscle. See? That's cool. So good for you. You're muscle. We like that. All right. So how we would find a scoliosis is just mildly. Who's your partner? Right here. Loretta. So we're gonna palpate or trace the spinous process, and yours curve right here. They don't go down. High five to me. Okay, can we use you? Okay, so here we had a evaluator who came in and they were palpating spinous processes, and as they traced the fingers, they noticed that their fingers did not go straight down, but the spinous process moved over to the side. So that is a sign that there's a little curvature there, a little scoliosis. Now she knew that already, so she's like, hey, high five, you found it. But that's what you're looking for. So you want to come palpate those spinous processes and just make sure. And when they don't stay in the middle and they seem to take you over to a side, they're showing you the curve. So you trace them.
I
It's
also
like
have a
necklace.
piece of muscle mass that comes out on that side. I think my scope, does it go that way or something?
Yeah, so it does. And that's just you. That's awesome.
Yeah, they found it in a little child in elementary school. I got over and they were like, oh, people said they're giving you a note home. I was like, I don't want to. That's how I found out. Yeah, go ahead.
Okay, so once you have looked at curvature and you have palpated, now what do you do?
Yeah.
Yeah, you ask them to move. So you have them flex, you have them extend, you have them side bend, and you have them rotate. And you're looking for, do they have the amount of motion I expect? Or are they limited? And then does this cause pain? And is it their pain? And then which directions cause pain? If movement causes pain, you're in the right spot. It's something in the L spine. So you keep going. You're like, oh, that's good. I know that.
Now I can do my yoga.
So have them move. Now our friends with scoliosis, as they bend forward, it's just going to stand out and be more obvious to us. After you move, if you're already ready, we've got beds in here. So you then can test your motor units. What is a very quick way to screen motor units? Walk, toe walk, heel walk. I've got my most important ones tested. So I asked them to toe walk for 10 feet. I asked them to heel walk for 10 feet. If they can't get on their toes to toe walk, that's a sign of weakness or balance. So I say that. If they can't get on their heels to walk, that's a sign of weakness or balance. So I notate that. Like I don't force them to do something they can't do or aren't willing to do. And so then I know I have to come back and I'm going to test it again anyway when they lay down. So when they lay down, I've got motor unit testing. And I use the ankle foot because hip weakness is very, very common in a patient with low back pain. And so it won't tell me that the nerve is compressed or not compressed because whether they have compressed nerve or not, they tend to have weak hips. So I can't use that even though that is a motor unit and it would work if I were looking at the anatomy book and it would be perfect. It's just that most people have it, so it doesn't distinguish it for me. Now, most people don't have big toe weakness unless they like broke their big toe somewhere in their medical history. That would explain that. And they're like, oh, so now we have to use eversion. Most people don't have weakness of the everters unless they sprain their ankle a bunch of times or acutely, and then they might. That's why we have more than one thing that points to the nerve. So we just have to be mindful of that. So I'm going to have somebody get a person on a bed, and we're going to test for straight leg raise and motor unit, and we'll do it together so we can say it out loud because this is a psychomotor skill, so you got to practice it so that in the moment it actually works for you. So if there can be a patient laying down on each bed, that's awesome, and then a cluster of I can test for sensation. So don't forget about your dermatomes. Sensation at the foot is your L5 and S1 dermatomes. So you can see, do you feel me touch the outside? Do you feel me touch the inside? Do you feel me touch the top? Or tell me when you feel me and you're touching all those dermatomes. You can use the shin and you can use the thigh for upper lumbar or the back of the leg for S1, because then as you go up the back of the leg, you go up higher into sacral levels. Okay, so I've got sensation. I've also got reflexes. I've got 2 lower extremity reflexes. Quadriceps or patellar reflex tells me about femoral nerve L4. and Achilles tendon reflex tells me about S1. So again, what would I expect to find in a patient with a compressed nerve? Pain, but what kind of reflex? Hypo, diminished, because the nerve is not getting the signal. If it's hyper, it tells me it's an angry nervous system, but it's not a compressed nervous system. So if it is hyporeflexive, then I will probably see sensation deficits and motor weakness, because they all go together, they all complement each other. Okay, and then if I want to test L5, I can test dorsiflexion, big toe extension, and turning the foot out eversion is L5S1. So practice a muscle test here. It is not, it looks easy, but you gotta really practice. So have them lift the foot up. If they can't get to a 90-degree angle, and just the toes, they don't have to put the whole leg yet, don't say that. If they can't get to a 90-degree angle, that may be weak. So, if they can't get there, but she can get there, so good for her, her gastron's not too tight.
You good?
But if they can't get there, she can relax. And then I just see how much motion is actually
Means everything
there.
is intact.
So let's say she stopped here.
Straight leg.
And I'm like, whoa, that's all you
That's straight
got?
leg chest.
I don't say that out loud. But I'm thinking in my
It
head,
takes you so many
that's not
things,
90
like
degrees.
kinetic
So I'm
disc,
gonna come
you know,
test it, and she had a lot more there, she just couldn't lift the muscle through it. That means it's weak. But if that's all she had, I tried to lift her foot and it just won't go anymore, well, that means she's got an ankle problem and I'm looking in the wrong spot. I'm like, okay, I gotta change her over here. Or she has a fusion or something. So to test strength and motion, I have to make sure that she's actually going through the motion that she has. So if I see a loss of motion, I need to check it passively and just make sure that it's not really a loss of motion, that it's weakness. Does that make sense? Okay, so you've got big toe, so try it. Let's see. Test muscle.
So you can, but if you weren't able to, then I would essentially help you get there.
Okay,
So we're going at a 90-degree angle. And if she had muscle weakness, then I would test to see like her limits. Yeah, passive.
What now?
It's a shortcut.
Like they have to do it like this way. You have to press it up from this.
That's for
You can do this.
There you
right
go.
now. I think it's just
Okay, just one of you, so.
You can do both. You can do both sides. This.
The other side too.
Yeah.
Okay.
Yeah. And then this. Resist me.
Decisions based on their ability to generate force. So if they don't go through the range of motion you expect, it could be weak. But you don't know that until you test it. So here, another thing that we will say is that to get a fair muscle grade, a 3 out of 5, they have to go through the full range of available motion against gravity. If they don't go through the full range of available motion, they don't have a fair muscle grade. That thing's weak, which means it can't hold them up, which is another problem. So we have to look for that. So when you ask them to move and they don't go through what you expect them to go through, you can't just go, huh, well, they didn't go through it. You need to test passive range of motion and make sure. Now, if they go ow, 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 well then, we're gonna be like, oh, that's pain limiting. And then we're not gonna really push them. So we just have to, okay. All right, do you feel good about that? All right, straight leg raise. Talk, someone, demonstrate to me straight leg raise. And talk the whole group through how to do it. You ready? Lift it up. You will never miss this again. See how awesome this is? All right, so passive. So everyone's gonna lift the leg up. If it's a nerve, it is often positive where in the range? Before 60 degrees of hip flexion. If I can get him past 60 degrees of hip flexion, then I can torture him and really rip on his hamstring, because that's what I would be doing to this one. Or I just say, okay, that's not a nerve. But I don't know for sure, so I lift him up. Okay, how do I sense, because he might be saying, oh, I feel that in the back of my leg. Do you feel something in the back of your leg? Yeah, so he's not flexible. He feels something in the back of his leg. But he says it's hamstring. But I say, I don't know that it's hamstring yet until I pull on your nerve a little bit more. So how am I going to pull on the nerve a little bit more? Dorsiflex. Well, I could. That's true. Or I can dorsiflex the foot and see if that makes the symptom more intense. If it does, that's a nerve. If it doesn't, well, he's right, it's hamstring. Okay? All right, so feel it and then test it. This is kinesthetic. You're going to have to do it, so just feel good about it. On your it's also on here that we have to think about. So we talked about nerve compression, and the straight leg raise is our sign that the nerve is pain. It's creating pain. The nerve is painful. If it's compressed, we will see what? Remind me. Diminished reflexes, weakness, sensory loss in the dermatomyotome. So that funny looking little picture of the dermatomyotome, that's like your best friend in life when you're trying to test nerves. Because it tells you who you've got to test. Okay, so it's not there. We'll have to, somebody push the back arrow on the computer. This will tell you where to sensory test for your nerve root, and it also tells you the muscles in that area also go to the nerve root. So this is really like a roadmap to understanding nerve. So it is a beautiful thing. Okay, now we didn't talk about, when we think neuro, when you're thinking neuro exam, there are peripheral problems and then there are central problems. Central problems meaning brain trauma or something that's involving the central nervous system that in this case would be more serious because back pain and central nervous system dysfunction don't go together. So that is a sign that this is not normal, and unless I know they've had a CVA or a brain injury in their past, I'm not expecting to find this. But a nice way to test irritability of the nervous system is through a clonus test. So how do you do a clonus test? Because you may find someone who's coming in with back pain and it is an acute sign of something really bad, like a meningitis or something not good. Involvement of tissue and irritation of the nervous system. I don't usually get that in my everyday life. That doesn't show up in a PT clinic, but you know, it could, so you've got to be prepared. So one of the things that we can do is a clonus assessment, which is a quick stretch of the muscle. So I do a quick stretch of the muscle, and then I see how does that muscle respond. Most of the time the muscle will be like, oh, and it may push you back one time. But a clonus response is when it continues to contract and you get this repeated response. And then you can actually count them. And then you get a however many beat clonus. So it pumped 2 times, that's a 2-beat clonus. It pumped 4 times, that's a 4-beat clonus. It pumped until I stopped it. I don't know, I didn't count that, so okay. All right, so I'm gonna come in, I just do a quick stretch, and then I see, was there a repeated contraction that maintained after that? That's my clonus test. That won't tell me about a compressed nerve. It tells me about an irritated central nervous system.
Is that pretty obvious though? Like,
It is very obvious, yeah. They push you back.
Slight.
Yeah, it's not slight. You push and it pushes you back and pushes you back and pushes you back. But try it so I can see you. Oh, yeah. How high do I take the leg for the straight leg raise? Okay, well this picture shows that they took the leg to above 75 degrees. All right, well that's showing off because you have super awesome hamstring length. But the reality is if it's a disc nerve compression problem, their symptoms show up early in the range before you get to the end of the hamstring. So if you lift up and you've gotten to the end of the hamstring, that really is muscle. But you don't want to get fooled, so you dorsiflex the foot and you plantar flex the foot. You're not changing the length of the hamstring, it goes to the knee. So if their symptoms get worse when you dorsiflex, and they get better when you plantar flex, you didn't change the muscle. So there has to be a nerve element there. Now the reality is I'm looking for their pain. And if this isn't their pain, their leg pain that they came in for, well, that's interesting, but it's not helping me because I'm trying to find their pain. They came in for me to find their pain. They came in for you to find their pain. It's like when you take your car to the shop and it's dinging. You want them to find the ding, fix the ding, you want the ding to quit. And so that's what's happening with this patient. So if you find new pain, so it should be their pain. So I'm looking for their pain. Okay, the other thing that you had on your list are these two things. Your Kernig sign. Did y'all talk about these in neuro? Or you read about them? So all I want you to know is that they're the same. So this flexion of the knee when the hip is flexed is because of the same tension. And the bending of the knees when you lift the head is because of the same tension. So they're all related. So if you lift your patient's leg up, and they extend their head, or you lift their head up and they bend their knee, that's all dural. It's just one big giant dural connection. So there's the relationship there. That's why that happens. It's because of dural tension. And that's why the straight leg raise works, is because of dural tension. So if I really wanted to make this worse, and it's a nerve, I could ask them to lift their head up. That would be mean, so we don't do that. That's why it's not in the notes. But I could. Okay, so any questions on low back? Because that's our exam. How do you feel about it? Feel okay?
They really don't.
Anything you want to practice longer? Here is you're looking at your grading rubric, which by the way is super awesome because you know what you're being evaluated on. And one of the things that it says, or ask your question. So it says that they are looking for you to verbalize recognition of what you're testing for by the instruction and interaction you have with the patient. So I tell students in a testing environment, we can't see that you're processing. You have to tell us you're processing. And it's always good to talk to the patient anyway, so now you're being evaluated in your processing by thinking and talking out loud, but you're also educating and instructing the patient. So I'm going to just borrow your foot. So the question was, what are they actually looking for me to say? So anytime you're doing something with the patient, you are explaining to them what you're doing, or they get really offended. But I don't always tell them, I'm doing a nerve test to see if it hurts when I pull your nerves. I don't always say that, because then if they wanted to be nerve, they could say, oh yeah, that hurts. Okay. And I don't want them. But I do say, okay, I'm going to lift your leg up, and I want to see what this does. So tell me what this does as I lift your leg up. Do you feel anything down the back of your leg at all? Now, she's not really that tight, so that's really cool. But if she started to feel a pulling sensation, because I will kind of take the patient until they feel a pulling sensation, I can tell that the muscle is like not really loving being here because I feel shaking everywhere. So her body's telling me she's not loving this. So I can, as I'm thinking out loud, I say, okay, I'm lifting this up. Tell me what you're feeling. What do you feel when I do this? Okay, you feel shaking? I feel that shaking too. So if I pull your toe back, does that seem to make it feel worse? It does. What if I flex your toe forward? Does that seem to make it feel better? Now I'm kind of leading, so be careful. But I can tell that she doesn't really like this nerve tension. I can feel it in her body. Sometimes patients are super stoic, not usually, but sometimes they are. And so you have to respond to that too. So this is just a nice, it's not in the rubric teaching moment kind of thing. But I can tell that she just doesn't love this tension. And so in testing purposes, if you're doing something, okay, I'm going to pull back. Does that change it at all? It does. And then you tell me how. Does this change it at all? then you want them to tell you how. If they just say yes, you're gonna be like, okay, good, how? Like, please talk to me, because I'm trying to interpret this, and I can't if you're not giving me data. So, or I can say, does it make it better or worse? Yeah. Because then I'm not leading her, I give her an option, better or worse. And if she's like hesitant, I say, does it stay the same? It doesn't change it at all. But you look for that. So you are thinking out loud in a testing environment for graders to know what on earth is going on in your head. So that is there. But you're also talking to the patient because this is a pain provocation test. So I need to know how she responds to what I do. So I have to go slow enough that I can go step by step. I have to ask questions about what she's feeling. And I'm always trying to figure out how is this modifying your symptom. So that's an excellent question to answer it. Yes. Okay. All right. Do y'all need a short break? Because we're going to move to the, yes? Yeah. Okay, so short break. So before we move away from the spine rubric, there's one more thing that's on that rubric. And it leads into lower extremity really well because I would do the same thing there. And it is balance assessment. So with balance assessment, when I have the patient stand up, and their ability to stand up and for me to look at their posture is my very first insight into their balance. So if they stand up and their feet are more than shoulder width apart, they are trying to increase their base of support, or if they're gripping to dear life onto the chair or whatever it is, or they came in with an assisted device. Okay, those are all signs that the balance isn't awesome. So we got to be careful of that, okay? Somebody's already evaluated, they have a cane. My favorite though is when they walk in the cane and they're carrying it and they're like, well, that was super helpful. That must be a protective weapon because that's the only thing that is swaying for you right this second. Because I can swing and knock you out. But when they stand up, they're giving me my very first insight into balance. And what I am looking for is how stable is their postural control when they stand up. Because when I start palpating their spine, I am putting a force into them, and some patients who don't have good balance, they buckle on you. So you just have to be very careful start with light touch and see how they respond to that input before you really do any kind of pushing of them. And if they can't take that, you know they have poor balance. So you're not going to really push them to the point where they would fall. You've already identified poor balance. But we do have ways that we can measure that. So Romberg stance is when we ask them to make their 2 feet, their base of support, as narrow as possible. So they put their feet together. And then we look at their balance. And if they have postural stability, no sway, then I can take the next step and I can ask them to close their eyes. Because when they close their eyes, they have to shift input from vision they have to reweight their sensory input to the receptors and their joints and their tendons and their ligaments, and we call that somatosensory, and their vestibular system because they don't have vision anymore. And most people who have poor balance are vision dependent, meaning that if you take vision away, their balance gets worse. And so that is a very easy way to find bad balance, is just have them take their vision away and see if their sway increases. Just be prepared to catch them, okay? Because they can sway and you go through different. So my first protective strategy is sway at my ankles. My second protective strategy is sway at my hips. My third protective strategy is to step or catch myself. So if you have them put their feet together and they start swaying at their hips, know that they are already on strategy 2. And if you ask them to close their eyes, be ready for catch, right? But if they put their feet together and they look steady, and they close their eyes and then they start to sway at their hips, well, you know that that's still not normal balance because they have increased sway, but it's not bad to fall. And then we measure this based on time. So how long were they able to stand and maintain that position before they lost their balance. So a normal number that we look for is 60 seconds, 30 seconds to 60 seconds. One, because we have very little time with the patient, so we have to be efficient. We can't make them stand there all day. And if they can stay there for 60 seconds, they could stay there all day, right? If they're gonna fail, they're gonna fail in the first 60 seconds. So that's a good enough marker. So we use that. If this is easy and you just feel adventurous, well, we can challenge them more. Or let's say they're 15. Then I can make them stand on one leg. Or tandem is 1 foot in front of the other. So all I'm really doing is the more challenge I put, the less base of support they have. The most challenging we can get to without putting them on a machine is standing on one leg. And then if they can stand on that leg and put weight on that leg, which look, I already swayed and went to like, oh, I'm gonna hold myself up. I didn't even close my eyes. So that's our progression. So Romberg is feet together. This is functional balance. When I take vision away, I force them to re-weight to other systems. And then that can tell me if they're visually dependent, which means they typically have a balance deficit somewhere. And that's meaningful. So that's also on your rubric, because patients who have back pain often have balance deficits, because actually patients who have pain often have balance deficits because your primary signal comes from your joints and tendons and ligaments. So this just lets me know how errored is that signal. It also gives me a sense of stability. So as we move to the lower extremity, which this is a good transition, when they stand and I look at their posture, I'm also looking at their willingness to put weight on. So someone who comes in with hip pain, knee pain, or ankle pain, one of the first things I want to know is, are they willing to put weight on it? If they are not willing to put weight on it, or they can't, and they come in like this, well, one, that's really good balance, and they must be under the age of like 40 and sprain their ankle doing like basketball or something. Or if they're not willing to put weight on that leg, there could be a problem with the bone, which then says, I'm not going to make them do a whole lot. I'm now concerned about fracture of bone. If they are willing to put weight on their leg, the probability of a bad injury like fracture goes down. And then I'm more willing to do things because I know I'm not going to mess something up even more. Now there are other big obvious signs of fracture, right? It's really swollen because there's blood leaking out from the broken bone, and it's bruised, and it's super tender to touch. So as we go through our rhythm of our exam, we'll be able to confirm that. But a lot of times patients who are coming in and they have hip, knee, or ankle pain, it is because something happened to them. And I have to figure out how bad is this thing that happened and what did it impact. So they're willing to load it is a start. Are they willing to stand on it? Are they willing to put weight on it? Could they walk in here, or did they spend $50 at Walgreens to get crutches that likely aren't sized correctly to get into the office? Or they got a wheelchair from transport, something. So we got to pay attention to that. Okay, so we are switching now to the MSK lower body. And we're going to start hip and we're going to work our way down. And with this one, as we move through, we're going to follow the rubric, but we have to keep in mind that our exam doesn't stop if they're not willing to put weight on it. So a lot of times with this, they're not willing to load it, they're not willing to put weight on it. So I have them in a position where they are not doing that. So almost always, my exam starts in sitting or lying down. So if someone will come here, I will talk you through it and then we will do it. You'll come, so you get to lay on your back and relax. Okay, so we're starting with the hip. Now, if she has hip pain and it's arthritis, she would actually be able to stand on her leg. Like, I'm not worried that she fractured her femur. She didn't fall that way. So if she's willing to, it's hip pain, and she's willing to stand on her leg, my exam starts exactly the same way the lumbar spine exam starts. So I look at what? Posture, alignment, height of shoulder, height of pelvis, alignment of femur, and where do the feet point. So when they come in and they're complaining at hip, I start thinking, I gotta look at L spine and I gotta look at hip. And I actually will make them move their L spine before I make them move their hip. So I will look at them standing, and then I will just make sure it's not L spine. So I'll say, okay, can you bend forward? Can you bend back? Can you bend right? Can you bend left? Can you twist? And then if they can do that, and it's not the L spine, nothing hurt them, we come to this position. If that did hurt them, then I still have to screen motor units, and then they end up, guess what? In this position. Okay, so I'm always looking, what are things that I have to think about as pain in the hip? Just give me some common stuff.
Sciatic.
Okay, sciatic nerve, which we're gonna think spine. So our same test is there, straight leg raise. What else?
Dislocation and fracture.
Okay, dislocation and fracture. Okay, fracture, they won't be able to put weight on it. And the leg might look, shorter and like that. Dislocation, they're gonna have a big trauma. And I'm really concerned about that, so I'm gonna look at their willingness to move. Because if they dislocated it, they need to have blood supply to the femoral head considered because of that ligamentum teres and just how it gets its blood supply. But I also have muscle around here that can cause pain. And I have arthritis, a labrum, and a bursa on that trochanter that can cause pain. So sometimes they're big bad things, like a fracture, and I'm concerned about that. Now the thing with fracture, if I'm really thinking that, then I can do something simple like this and just see if they're willing to move, and if it turns. I can also do this thing called a pubic percussion test that's not on your list, but I can take my stethoscope, ask them to place it on their pubic bone, and I can tap their kneecap, and I can tap their kneecap. And the nice thing about bone is that sound will transmit through it. And if one side sounds dampened or less resonant than the other, and that's their symptomatic sign, I'm like, uh-oh, something in the bone has impacted my ability, that transmission of sound. I am now more concerned about fracture. The other thing I can do is use vibration or a tuning fork and just place it on the boniest thing in the hip I can find, which is the greater trochanter. So I've got to be able to palpate the greater trochanter. So that is one of the things. So when they're standing, I look at hip height. I look at alignment of the leg. I look at willingness to load. I also may make them just squat and come up, because if it's hip pain, it usually hurts to squat and come up. So that works. Then they will lay down, and I look at the same thing here. So I look at how are their hips aligned, are their toes pointing up, or is one rolled way out like that? If it's rolled way out like that, they are either really relaxed and don't have white coat syndrome, or something's wrong. So I look at that. Then I can come and I can palpate that greater trochanter. Now, can you palpate your own greater trochanter? Okay, so there's a trick to finding the greater trochanter. If you find the top of your iliac crest and drop your fingers down, you will hit the very top of that greater trochanter, and then know it's a big inch. So you can grab the whole thing. So on you, that's easy. Find the top of my hip, drop my finger down, boom, I found it. On a patient, you're like, huh, okay. Okay, but know that it is really about pocket level at the same time. So I can put my fingers on the top of the iliac crest, drop my palm down. I now know the greater trochanter is right there. So I can find it using the iliac crest. I also know just anatomically it's almost horizontal to pubic rami, which is another just good eyeball thing. So if you're trying to grab it too high, you're just going to be in the glute med, and you're just getting some muscle. So horizontal to pubic rami is another nice landmark. You'll get right on it, and you can find it. Many patients have pain here. It's called greater trochanteric syndrome, or trochanteric bursitis, sometimes you might have heard. But if I grab here and I reproduce their pain, well, I found it. You know, I found their pain. It's at the trochanter. IT band is here. It starts around this area, and my glute med inserts at this area. So there's some things that can cause pain there, and then I've got it. I found it. I found the source of their pain. So I want to be able to palpate those, and then just make sure they're in the same spot, right and left. I can also look at the length of the leg, malleoli, and just make sure one leg doesn't seem much longer than the other. Okay, then the next thing that I do after I look and I touch, we got to be real careful touching soft tissue in this area. But I do have a major artery that runs here, so I can look for tenderness along the inguinal line and find that femoral artery. I mean, I want to check for that if I suspect that there's something vascular going on. Okay, then the next thing that I ask them to do after I look and touch is what? Move. So the hip moves flexion and extension, so I'm just going to have her bring her knee up and see how high does she go, how much does she flex. Well, I expect her to flex past 90, right? 120 is typically normal. If she can't get past 90, I'm really worried. So I'm looking for that. She is perfect. She's normal. She got past 90, which means she can sit in the chair. So that's good, right? That's good. So I'm happy without that. I'm also looking to see, does this hurt? And if she doesn't hurt, I'm going to come in and just make sure that's all she has, and make sure that flexion doesn't hurt at the end of the range. So she made it to here. Her hip flexor is pretty strong. I just make sure I give a little passive in-field test, see how it does, and see if that hurts. If that reproduces her pain, I've just taken her femur and pushed it into her acetabulum, so that lets me know, hey, I'm in the right spot. It's in the hip joint, and it's more likely to be joint pain with that. Okay, then I really want to look and see, can she get her hip to neutral or extension? Some patients can't. They won't let the hip relax all the way, so that's important to know. I can also look at, can you bring this leg out to the side for me? So that's abduction. How much abduction does she have? It lets me look at tightness of the adductors and strength of the abductors. And then can you pull it in? And then that lets me look at strength of just general functional strength of adductors. So she lifted it up, she straightened it out, she kicked it out, she pulled it in, and I'm looking, does any of that cause pain? If I have caused her pain, I've reproduced her pain, I'm in the right spot. Something's going on in her hip. Okay, now if something's going on in her hip, she will have a loss of hip flexion. She won't get all the way to 120. So a lack of hip flexion also tells me something's going on in her hip. And then she can straighten it out. There's a special test that I can do. Before I do that special test, I will also just look at how much external rotation is there, which by the way, that's a lot. And how much internal rotation is there? Not so much. So you must have like played sports as a kid, huh? Like basketball, soccer, some, no gymnastics, some, okay, something. Okay, so if she has a significant loss of internal rotation or pain with internal rotation, and it's right here, that is also pointing to a problem at the hip. It could be an impingement type of syndrome at the hip. And so that's pretty common in some of our athletes who are it starts showing up around 15 all the way until they get arthritis. Because we can find this impingement syndrome. The more active they are in loaded lower extremity sports, the earlier it shows up. Dancers can also get this, partially because they sublux their hip with about half the stuff they do. So we just have to be mindful of that too. Okay, so I look at how much flexion does she have. A loss of flexion points to a hip problem. And then I look at her ab and adduction. Does she have the strength to make that happen actively? If she doesn't get to 45 degrees of abduction, I just come test it. I will also look at internal and external rotation. So going towards her head this way is external, and going this way is internal. She should have 45 degrees and 40 degrees. She has like 75 degrees. So she has more external rotation. She's not limited in that motion. In my mind, I'm just like, she looks like someone who gets impingement. So I will know that. That's just what that looks like. Okay. So then the other thing that I can do here is test the strength of her muscles. So muscles that commonly have problems in the hip are the abductors and flexors or extensors. So I'm going to test the flexors. So I'm going to ask her to hold here. Don't let me push down. So hold, 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 hold. Now I can do this while she's laying down, or I could do this while she's sitting. Either way, but I do want to test the strength. Because this muscle, this iliopsoas, it's famous for getting a tendinopathy. So I want to see, does that reproduce her? Okay? And then I can test abduction. So can you push out into my hand? Like try to spread apart your legs apart, but I'm not going to let you. So I can test her abduction strength, and then pull in, and I can test her adduction strength. So I can look at that here, or we can do that in sitting. But this is nice. A perfect way would be against gravity, which means she has to lay on her side. So I'll just show you. She laid on her side. I just really win this way. So I have her lift her leg up, hold, don't let me push down. And we usually just way overpower, because this muscle is often weak in a lot of people. So sometimes you get enough testing at sideline. Okay, so you can go back to your back. So the provocative maneuver that you have on your handout for this region of the body is called FABER. FABER is just an acronym. It stands for flexion, abduction, AB. So F, flexion, abduction, AB, and then external rotation, ER. So that just tells you the position you put the leg in. So I'm going to passively flex her leg, place the foot on the opposite knee. I'm going to come stabilize this ASIS, or pelvis, and then I'm going to let this leg drop down. This test tells me a lot, so we just have to think out loud together. So as I lower her leg down, I am looking for how far does her leg go down. Okay, she has no problem bringing that leg down, right? It makes a complete figure 4. So this tells me her adductors are not tight. Now technically I already knew that, right? Because she nearly did the splits over here. So I knew they weren't tight, but okay. So that tells me they're not tight. So that if she stopped right there, And I said, well, what do you feel? And she says, I feel pulling in my groin. Guess what she has? Tight adductors. So this test can tell me, does she have tightness? If she reports pain right here, deep in her hip, this test tells me, yes, her pain is coming from in her hip. So it's a hip problem, intra-articular hip problem. If you did this to me, it would pop. Well, that's still an intra-articular hip problem. It's just popping over a labral tear. So you may experience that. It's pain, it's their pain. It's right here in the middle of that femoral triangle. It's deep in the hip joint. They're literally pointing to their hip joint. That's where it's at. And so this is positive for hip joint symptoms. It could be OA, it could be labrum, but it tells you it's coming from the hip. And that's honestly what we need to know. Is it coming from the hip or is it not? And then we've tested the hip. So what did we do? We had her stand up. We looked at alignment of the pelvis, alignment of the leg, willingness to load. Is she willing to load it? Sometimes I make them squat. Then I get them to lay down because now there's no load on it because OA hurts when you stand on it. And so I can come look. And I can still look for symmetry of the pelvis, tenderness of the greater trochanter, alignment of the leg, leg length. Willingness to move, can she flex? So pull that leg up. She gets past 90 to 100 degrees, so I can just give a little bit of overpressure and see if that hurts. Pain at the end of the range, whatever her range is important to know. I reproduced her pain. I can have her kick her leg out, bringing it to me, and then pulling it back in, looking at how much abduction, is her adductor tight? How much adduction does she have? Is it strong enough to do it? If I wanted to, I could test the strength of that. So people who have a glute med tear, I'll say, okay, try to spread that leg out, but I'm not gonna let you push into my hand, push, push, push. Oh, she popped her knee. Push again. So one thing she's trying to do is use her external rotators to help her, but I didn't let her. So I knew that because she turned her foot out to push. So make them keep their toes pointing up. Don't let them cheat with other muscles. Hold and now push into my hand. Keep your toes up, keep your toes up, keep your toes up. She's not as strong when she gets to just use that glute med muscle, the abductor muscle. So patients are smart. They try to cheat on you. Just catch it. Say, that was a good try. Now let's do it again this way. And then let's see. Because I'm looking, she wants me to find her pain, so I need to try to find her pain. And then I can pull in for adduction. Adductor strains are very common here. And if you pull a muscle, it hurts to stretch it, and it hurts to contract it. So I'm going to reproduce her pain when I stretch it, and I'm going to reproduce her pain when we contract it. So that's what I need to know. I'm looking, can I find her pain? And if I found her pain, boom, I've got my answer. And then I can move on. And then I want to look at internal and external rotation because a loss of internal rotation is important to know. Pain with internal rotation is important to know. So there are some really bad things that can happen here. I can get an infection in my psoas, and then hip flexion hurts. They won't go all the way. It hurts to contract that muscle, and they're really, really sick. And I can also get joint infection or problems in the joint, and that often will show up with all these painful tests, and then they have a significant loss of internal rotation. So pain and a loss of internal rotation is important to know. That's key. It points back up to the hip. And then I have my provocative maneuver, which is called Faber. It will tell me if the adductors are tight, she won't be able to go all the way down, or if I reproduce pain in her hip, it's positive for hip pain. You ready to do that from the top? Okay, your turn. Let's go. So laying down, tell me what you're looking for out loud.
Symmetry.
All right, symmetry. So pelvis is the same height, trochanter is the same level, toes are pointing in the same direction, and the leg looks just as long on one side as it does on the other.
Okay.
Make sure you see all of that. If we see a problem with that today, let me know, because that's bad. Okay, once we inspect it and touch it, we get to move it. All right, so the hip flexes, extends, abducts, and adducts. So let's watch them. Flex, extend,
I just think like lateral valvulosis.
abduct, and adduct. So she does it first, and then if she doesn't go So the question was active versus passive. It's always safer to let them move their body first. And then if they don't go far enough, you test that motion and see. Are they stopping because of pain? And if they are, yes, we found it and we respect it. If they are stopping because of weakness, we will know because there's plenty of more movement to go. They just couldn't go through it. So ask them to move, and then we're going to contract and test muscle. So we moved, we stretched some muscles, and we moved the joint. And now we get to contract muscle. So you resist hip flexion, iliopsoas pain. You resist abduction, glute med abductor pain. You resist adduction, groin strain. Yep, she pushes it out. Then your two provocative maneuvers, things that are a little outside the box, are looking at internal and external rotation. Honestly, you should have about 45 degrees of both, internal and external rotation. If you don't get at least 30 degrees of internal rotation and it is painful, that means a lot. And then you have Faber. So how do you do Faber? Alright, so you take the leg that you're testing and you put it on the opposite knee. Stabilize the pelvis and slowly let that leg drop.
All right, thank you, sir.
It will test adductor length a little bit more than hip flexor because of how I end up lining out. It's an adductor stretch. So whoever taught you to flex off,
Alright, so you guys want to try or?
Faber.
So we're going to do Faber over here.
So Faber. Faber is a name of a position. That's all it is. But someone found out that this position is pretty sensitive at picking up hip joint problems. So Faber is a position of flexion, abduction, and external rotation. Now, what's confusing is that technically I'm bringing her into extension, abduction, external rotation. She started in flexion, and I'm bringing her into extension. But whoever named it didn't call it X-Aber. They called it Faber. So I start in flexion, that's why it starts with an F, and then I move them into abduction, external rotation. So it's all one. You could also call this the figure 4 test. In old ortho books, we call it the figure 4 test because she looks like a 4.
Remember the figure 4?
And so that's another thing to call it. And then it tells me a lot of stuff. So it's a really cool thing because it tells me if her adductors are tight, It's positive, it's a provocative test for hip joint pain. So what would make it positive is the fact that she has pain in here. Because that's what she's coming in for. She's not coming in because her adductors are tight. She's coming in because she has hip joint pain and she wants me to find it. So if this test is positive for reproducing her pain, it tells me that her pain is coming from the hip joint. Right. So just confirm.
Determine there's pain there, then what?
For yours,
What?
You
where do you
determine there's
hurt?
pain there, then what?
Well, I know her pain is coming from the hip joint.
That's all we're good with.
Well, so at that point, I have other tests I could do to confirm what it is. But based on her, it could be avascular necrosis, it could be arthritis, it could be a labral tear. I can't make that decision without imaging or a bunch of additional tests. So it tells me where I need to focus more investigation. Yeah, so I don't have all of the answers from this one, but it says, no, this is definitely coming from the hip. I found it. And then it could be a couple of things, but I know it's from the hip. The question was, how far should I take this favor? And then I'm demonstrating it to you, and you're like, wow, she is like all the way into a real figure 4. And then the patients we were using were very much into a figure 4 because they did not have adductor tightness, and they probably have a lot of external rotation. So here's the thing though. If I am putting the hip in this position and I try to push it there, you could dislocate their hip, right? So I'm just going to be really extreme and teenage drama queen and tell you that's bad, right? You could dislocate their hip. So this isn't a push it as far as you can kind of test. This is a, I put it here. And I'm real careful with this one because it makes my hip pop every time, and I know I pop, so I know a patient might pop, so I just let it go, and I'm supporting it, and I won't let it drop. Some people will let it drop, but I already know that this could be bad. It hurts me. I don't love it. So I never make my patients go through it very like that. So I will just support her. I see where she's willing to go, and wherever she stops, I stop. Or wherever her pain happens. And if she gets to here, because it's really called a flexion, abduction, external rotation test, because most people don't end up in neutral. They stop somewhere in flexion. And then this is normal. And she should be the same side to side. I will not push her past what she's willing to go. I just see what that is and see how it feels. And if it feels like there is tightness in this muscle, meaning it'll hold itself up, I move my hand and it holds itself up, then there's tightness in the muscle. But if she has pain, that test is positive, and I'm done. If it reproduces her pain. So if it reproduces her pain right there, I can confirm that, you know, there's tightness in the muscle, or I can know that I could go a little further, it's empty infield. But I'm done. I don't push it past her pain. Because what's happening with that femoral head is it's coming forward. That's what makes this a joint pain test, is as the knee goes down, the femoral head comes up. And if they're a really lax dancer, if I push, it will come out. And that's not cool. So just where they go. So the question is how far?
There's a difference between tightness and pain though. If
There
there's just
is.
tight, you continue pushing? Do you push
I
all?
never push through anything. If
Not
there's
this time.
tight, I know it's tight because it just doesn't go. Like it just stops. It literally holds itself. We can find someone in here.
Oh, right here, she's here.
She's here.
That's what we were asking.
Yeah. So when it stops, it stops. Whoa, those are some tight adductors, and then I notate that. But the test is provocative. Yeah, that wins.
And we pushed against it when we were
Yeah.
supposed to.
Well, that's okay. You just knew it was tight.
But she, when we did it a few times, I guess she stretched
Yeah,
her.
so we elongated her muscle. That's good. That's therapeutic.
Ah.
You could have charged her a therapy charge.
Oh.
Right, yeah, so that's tight, but it's not
Tightness or
painful.
pain, you stop, you don't push it all.
I never push this one just because it's a provocative test. And I'm I'm conservative. Like, I'm not gonna hurt someone that I don't intend to.
And if they have pain, like, she was saying she has more pain, is it because of your size, like she said? That's not necessarily the hip pain then?
No, it is hip pain, but it's on the side. It's greater trochanter. So if she gets pain on the side, test the muscle and see if that reproduces the pain. Palpate the greater trochanter and see if that reproduces the pain. And then her favor pointed to her greater trochanter, not to her hip joint. And so that could do it too, because she's having to control that movement. You can also just pinch the joint back here. It's called posterior impingement. That's just more rare. So we didn't talk about it. But it can happen too. So if it hurts, like if that hurts for her and she's that tight, she's probably just got some tenderness in the greater trochanter. You squeeze it and you'll find it. She'll let you know.
Did I find it?
Yeah. Okay. All right. How are you with that? Okay. So I'm gonna challenge you a little bit. We're gonna stay in this position and test the knee. Okay, because the hip and the knee are the same bone, at least in part, right? It's still the femur. So now they're laying down. I need to look and inspect the knee. So what do I look for and inspect at the knee? Any deformity, any discoloration, any swelling. So my bone that helps me in life that I love with the knee is the patella. So I want to be able to find the patella on both sides, and I want to be able to see the patella, because patients will fracture this cute little sesamoid bone, and I'll know it because I touch it and they are screaming, and then I can just squeeze it a little and they're screaming more, and then I'm like, oh, hey, we need to go get an x-ray. Okay. So she wouldn't be able to put weight on her leg. She wouldn't be willing to put weight on her leg, because she has to use the quad muscle to do that. And the little bone that lives inside of that muscle is broken. And so she lays down, there's going to be swelling, there's going to be bruising. I may not even be able to find the kneecap, but then when I do find it, it's tender to touch. So at that point, I'm like, oh, okay, I got most of my information. But that's not her, so I don't have most of my information, so I gotta keep going. So I come and I look at the kneecap, and what I'm looking for is, can I find it? Do I see quad definition of muscle? And can I see tibial plateau? And then some of us look at our knees and say, oh, they look a little fat. Well, that's because there's a fat pad right there. And so I want to make sure that I can see that fat pad. If I don't see these cute little indentions, that's swelling. And so I can look at one side to the other. I'm looking for symmetry. If there's a lot of swelling, it will fill up. There's a little empty cavernous space on the top of the quad, and it will fill up there. So I can come in and push that down. And then the joint line is right there, so I can come in and push that up. And then I can tap on the patella. And if there's a lot of swelling, that patella was floating, and I can actually push it down. Okay, my patient has no swelling, so when I push on her patella, it's already down, so I don't have to worry about that. I promise you, you don't miss joint swelling. Like, we can see it, we can measure it. It looks very good. It's like, do you have a patella? Because I can't find it. Okay, so I look for the patella, and I look just to make sure I can see muscle here and I can see muscle here. And then one of my first tests is, are they able to contract this muscle? So I'll say, can you squeeze? And I just look, and I'm already testing willingness to and how much extension she has, and can she contract this muscle? If I can't see the same amount of muscle on this side versus this side, that's bad. Now, if I am concerned that she may have torn her patellar tendon, I will also just come in and palpate. So I have a tibial tuberosity and a patella. The patella should point to the tibial tuberosity, and between them is a tendon. So I should be able to palpate that tendon, and find it. So with your partner, do that. Look and make sure you can see knees. That you can find the tibial tuberosity and you can palpate the patellar tendon. So I can get on either side of it and literally wiggle it. I can get on the patella and literally wiggle it. Make sure you can do that. I'll find you if you can't.
It's a bone.
Second, that kneecap. Some of you are stiff and some of you are wiggly. The kneecap should move 1/3 of its width. If it's not, they are really stiff. If it can move more, be very careful. You could dislocate it. Don't try that. Tears in the knee are very common. The ones you can palpate are the MCL or the LCL. So on the middle side of the knee, if you're in the joint line, the MCL is 1 inch wide. It is huge, and it's on the medial side of the knee. So if you take that joint space and you go medially, you're going to strum across the MCL. It is 1 inch wide. It's huge. And it goes from the adductor tubercle to the pes anserine. So basically the femur to the tibia, 2 inches. So in the medial joint, MCL. Okay, so then the next thing that we have is we want to look for the joint line because that is also on your rubric. So we're still inspecting. So once I get to this spot, I've got to be able to palpate the joint line. Now honestly, the joint line is easier to find when the knee is flexed because this is the joint line, the connection between the tibia and the femur. So if they're sitting, I'll be able to find it easier.
Might be weak.
When their knee is extended, the patella, the width of the patella is kind of floating above the joint line. So the joint line is roughly 2 centimeters below your corners of the patella. But you can come in, and if you rub your finger from side to side, you should be able to feel the space between the tibia and the femur. LCL. So the bad news is we can't palpate either ACL or PCL because they're inside in the middle of the knee. So we can't palpate those. Only the ones on the outside. So MCL and LCL. LCL feels like a pencil. It's thin.
They're easier to feel yourself. You feel like it feels like a cord.
Okay, so many of you are finding the hamstring, which by the way is really good because that tears too. Okay, but if you find the hamstring, and here's, I'll help you. So have them just dig their heel into the mat a little bit, and in the back of the knee, you'll find both the medial hamstring and the lateral hamstring. So find the hamstrings first. Okay, so the hamstrings are posterior. So now move yourself towards the front of the knee. For the LCL, you're going to go 2 centimeters. So you literally roll off the biceps femoris and you're going to find it right there. And the MCL, it's just flat and 1 inch wide right in front. Now, if you can't palpate it in your patient and it's swollen, well, it may not have tension in it anymore because it's torn. So that's okay. But we don't make that assumption yet. Okay, so once we look and we palpate and we look for obvious deformity, so look at your partner's knee because theirs is normal. And then anything outside of that is not normal. Now in your handout for your testing, it talks about a milking maneuver for fluid. So there's lots of ways to do this. So one of them is literally, It's called milking because you push the distal fluid to the joint, you push the proximal fluid to the joint, and then you tap the kneecap. So that was that ballottement test. We could also push the fluid top because that cavern is bigger. So I'm going to take the top of the knee and I'm just going to push towards the joint. And then I can squish the fluid from side to side if it's actually in a capsule. So I can do that too. But it's milking because I'm really pushing it into one spot. And then I can tap, if there's a lot of swelling there, I can tap the patella because it was floating and now I push it down. Or I can move the fluid from side to side because I made it more obvious. So that's milking it back, containing it so I can see it. On her, nothing, but if it's positive, it'll hit the So if the fluid made it float, and then I touch it, and it hits the femur. It'll float. Okay, so for you, because you're asking 3 questions, but the patellar test, if there is fluid in the knee, and you milk it to the middle, it lifts the kneecap up. And so now the kneecap is floating on a pillow of fluid. So when you tap, you hold that and you tap the patella, you push the fluid out of the way and it hits the bone. So a positive test is I actually feel the patella push the fluid away and hit the bone. None of you have that much swelling in your knee. So when I push all the soft tissue, which isn't fluid, it's just soft tissue, to the middle, and I tap your patella, your kneecap, there's a non-dramatic nothing response, right? Nothing happens. It doesn't tap, it doesn't move, I didn't displace it. That is a good sign. Because that means this thing's normal and it's not floating on a fluid pillow. So a positive test is I actually move the patella into the femur and it taps it. That means, whoa, a lot of swelling.
So it comes back up, or it's supposed to stay down?
I actually can move it down. Because right now, do it. Right now when you tap it, nothing happens. It doesn't go anywhere. I don't move it at all. There. Because it's not floating on anything. Right. So it's not dramatic. So a positive is something actually happened. The patella tapped, it moved, it was on fluid. Now that takes a lot of swelling. So sometimes patients don't have that much swelling, but they do have swelling. And in that case, I can still push it. The kneecap may not float, but I can actually move the fluid from side to side. Again, none of you have this. So unless somebody has a really, does anybody have knee pain right now? Nobody? Okay. So again, it's just this fluid is contained in a sac, and I can actually move it in the sac. However, you could use that test, or you could look at it and go, yep, it's bigger than that side. It's swollen. So I mean, it's a kind of the same thing. So we do that. The patella just tells me how much swelling. Because if that test is positive, that is massive swelling inside that capsule. It's a lot.
If you're seeing it on one side or the other, what do you?
Yes, because they usually only have a problem on one side. Yeah. So that's always my standard. The symptomatic versus asymptomatic side. If they hurt both legs, I'm like, uh-oh. Because I just lost my gold standard. Okay, so I've touched. So the next thing that I do is I ask them to move. So the knee really just moves up and down, the hinge joint. It will rotate, so I can test that, but it moves up and down. So I'm going to ask her to flex her knee, and I'm going to ask her to extend her knee. If she has swelling in that knee, it will not fully flex, and it will not fully straighten. So it won't move as much as the other side. And the flexion will be more limited than the extension. And she will prefer this position right here. She won't be able to get it much straighter, and she won't be able to bend it much more than 90. So when I see that, I'm like, yep, that could be a knee problem. But what do I have to do if it's not full motion? I have to make sure. So I have to come see if she'll let me bend it more, but most of the time they won't. But sometimes they will, so I just check that. And then I have to see if she will let me straighten it more. If it's swelling, it really won't. It'll just feel boggy, like, ugh, that didn't feel normal. And it won't straighten more. So a loss of range of motion points to a problem at that joint. If it doesn't move like the other side, and it reproduces their pain, then the pain is coming from that joint. Okay, I have one special thing that I have to do here. So I palpated ligaments. So guess what I have? I have stress tests for these ligaments. So in your handout, they go McMurray, anterior drawer, posterior drawer, varus, and valgus. In real life, I go in the reverse order. Because McMurray requires full knee motion to do. And if they've torn their MCL, LCL, ACL, or PCL, they don't have that. So we're going to go in the reverse order today, but we are going to cover them all. So varus and valgus stress testing, I am going to push on her knee to put tension on the medial ligament, and I'm going to put tension on the lateral ligament. And I'm seeing two things. Does this cause her pain? And does it actually stop? My first full MCL tear that I ever felt, when I pushed, it didn't stop. And I honestly thought I broke their knee. Like when you get a positive, it is dramatic. Like it just, you know, like, whoa, that's not supposed to happen. It's not supposed to move that much, and it does. Okay, so to test MCL and LCL, I do a valgus test for the medial side, which basically means I push medial. And I do a varus stress test for the lateral side. So that's the first thing you have to remember is push medial to test medial valgus, push lateral to test lateral varus. Okay, so if their knee is swollen, they only get to 30 degrees, and I test this in 30 degrees. So their knee has to be flexed to 30 degrees. Most of the time, that's the best they've got. Then I have to come in and stabilize the tibia, and I put my hand right at the joint line. So the joint line is right here where my carpal tunnel is, and I push. My forearm is showing you where I'm pushing. I push medial. And her MCL is intact. So I push, I feel it get tight. It doesn't move. A positive would be it hurts her there. That's her pain. And that's good because it's still primarily intact. Or I push and it moves. And it gives a whole centimeter. It gaps. I can actually shift the tibia over. That means it's torn. Okay, so then LCL, I do just the opposite. So now I'm on the medial side and I'm going to push it lateral. And I'm going to feel the stop. Now I'm doing this, I don't have to hold, I have her legs supported. In the clinic though, patients are guarding, and I love legs, so I hug it. Hi, I love your leg, it's awesome. And then I will push medial, support it, push lateral. I tested 30 degrees. If I can, and she can get to 0, I'll retest it at 0. But the most important part is to test it at 30. So I've got her legs supported. It's not going anywhere. I do a varus stress lateral, a valgus stress medial. Your test for ACL is called the drawer. So I have to put her into 80 degrees of knee flexion at a minimum to do this test. Most of the time, this is all they've got. So I try to get them where I can. She's at 80 degrees of knee flexion. not quite 90, so I can back her off. It doesn't have to quite be 90. I want to stabilize her. I'm going to pull her tibia forward and see if the ACL stops me. And then I'm going to push her tibia backwards and see if the PCL stops me. So posterior drawer, PCL. Anterior drawer, ACL. So I'm going to show you the PCL because you can see it a little better. So I'm going to come on her tibial tuberosity. I'm going to stabilize her femur, and I'm just going to push. And that PCL is lovely. It goes nowhere. I push and I feel that stop. Okay, ACL is deceptive because I've got to grab the tibia, and it is here, it's not covered by muscle mass, but here it is. So for ACL, I have to come in. I've got to grab the gastroc, push into the tibia, make sure I have it, and then I'm going to pull it forward. And then I am measuring how far forward does it go. If it is torn, it will move a full centimeter or more. If it's completely gone. If it moves more than the other side, it may, but not a full centimeter, it may be partially gone. But I always compare to the other side. Now, sometimes they guard, so another way I can do this is sit on her foot. I don't have to stabilize the femur now that I'm sitting on the foot. I put my thumb in the joint space, I grab the tibial plateau, and I pull. And then I just make sure that there's not more than a centimeter gap in my thumb. Doesn't slide forward. So these tests are different because they are in-field tests. It depends on what I feel and how much motion I create. Faber is just, does it hurt you or not? But this is a true in-field test. So let's practice them together. All right, so you have a person laying down. I'll make sure we all get to do it. So someone's laying down. I'm going to set you all the way up. Okay, so your patient's laying down. You want to test the MCL. So their knee needs to be in 30 degrees of knee flexion, right? So put them in 30 degrees of knee flexion. I'm going to try it. Okay, so MCL, your hand, you're going to stabilize the tibia. And you are going to put your mobilizing hand on the joint line. And you're going to push, so make your forearms look like mine. That way you don't push it crooked. So you are going to push vertically, like in a 90-degree or vertical orientation to the joint line. So you're going to push medial for MCL. You're going to push lateral for LCL.
Are we doing drawer tests?
This is a grade 2. 10 millimeters, which is a centimeter, is a grade 3 tear. So I have a stabilizing hand and a mobilizing hand. So clean, I really just want one hand to detect the motion, the other one just blocks. And then it's easier. It's just too hard to feel movement when I got to measure two things together. Drawers. We got an anterior drawer and a posterior drawer. If the patient says, I hurt my knee and I felt a pop, it typically means I need to check this ACL because a pop sensation is an ACL symptom. Like I tore that thing. It popped and my knee gave out. So if they say pop, I'm like, uh-oh, I better test this ACL. So my test for the ACL is the anterior drawer. So between valgus testing and anterior drawer, the position of the knee changes. So varus and valgus, the position of the knee is what? 30. So for drawers, the position of the knee is 80 to 90. We'll say 80, because if they're swollen, that's all you get. So let's put them in 80 degrees of knee flexion.
Here's
your drawer. Literally, you're gonna pull the tibia forward like it were a drawer. And somebody thought this reminded them of a dresser. I don't know. So you're gonna try to pull the drawer out of the dresser. So you're gonna try to pull the tibia forward. Now the easiest way to do this is to just block the foot with your hip. It's just easier, I promise. You couldn't see me, but it's easier. Okay, now you are gonna put your fingers on the back side of the tibia, kind of in the meat of the gastroc. So you're as close to the joint as you can get, but you are on the tibia, which you have to be if it's bent. Like you can't get higher. All right, your thumbs are going to go in the joint space. So you want to feel the tibial plateau with your thumb. And then you're going to pull it towards you. Now don't rip their ACL, but when you pull it towards you, it doesn't open, right? It's a closed drawer. So you pull it towards you, and it stops. That's an intact ACL. But if you pull it towards you and that drawer creaks open by about that much, which means the tibial plateau comes into your thumb, that is a positive drawer. So if it moves more than a centimeter, that tibial plateau moves to you, that's a uh-oh. Your ACL could be torn. Okay, so try it. Okay, posterior drawer is the opposite. You're trying to close the dresser. So in this one, you can stay sitting on the foot if you want to. You don't necessarily have to because you're not pulling it towards you. But get on the tibial tuberosity and just push backwards. And you're going to find that that drawer doesn't close because your partner has a PCL. You feel a firm stop. Okay, so you're feeling normal, so that when you find an abnormal, you know that's that. Just then go. Most of whatever movement we're getting is okay, the last thing on there is McMurray. So McMurray is for meniscus. So if you like to memorize things, it's M&M. McMurray for meniscus. So McMurray is a little bit more complicated. I have to rule out a big trauma before I can get to this one. That's why I always save it for last. Because if they tore their ACL or PCL, or if they tore their MCL or LCL, I'm sending them for imaging. I am sending them to ortho. I don't need to test their meniscus. Like, done, I found a big problem. So I don't go in the order that it is in your handout because I can't test that one if these problems exist. But if I rule that out, so I ruled out LCL, MCL, ACL, and PCL. She has awesome ligaments. I also have probably ruled out massive swelling because to do the McMurray test, she has to have at least 115 degrees of knee flexion. So with this test, I put her in range flexion. Whatever she's got, that's where I have to start. And then with this test, this hand is my stabilizing hand, and I am going to block the proximal femur. This hand is a hand that's going to push the tibia into the femur. So basically what I'm trying to do is I'm going to try to take that meniscus and do this. Okay? So this is a pain provocation test. Like I'm just going to squeeze that thing. This is not my favorite as a patient. Okay, so I just want to keep that. It's not my favorite as a patient. All right, so here I am. This hand, all it's doing is creating a counter force for this hand. because I'm pushing the tibia into the knee. Okay, so that's just step one. Step two is I have to either externally rotate the tibia or I have to internally rotate the tibia. If I externally rotate the tibia, I'm testing the medial meniscus. If I internally rotate the tibia, I'm testing the lateral meniscus. So we'll start with medial because it tears more likely. So I'm going to hold and then compress and extend with the tibia in external rotation. And then for the lateral meniscus, I'm going to internally rotate, hold, compress, and extend. Now, most of our patients had tight hamstrings. We figured that out earlier, right? So we're not going to lift them up this way. A lot of times with McMurray, I just let their hip extend a little bit so I can finish out that maneuver. Let their hip extend a little bit so I can finish out the maneuver to take them all the way to extension as much as I can. So this test is a twist, slam, move.
Nice.
Kind of what it is. So if you like that zip, twist it, pop it, zap it. That's kind of what it is. All right, so I end range of flexion. So she has to have more than 90 degrees to do this. Externally rotate, compress, and extend while maintaining the compression. I test that medial side. I have like really tested her meniscus pretty good. A positive is her pain or her pain and I feel a pop or click in her, I actually will feel it in her foot because it transmits down the tibia. So she pops and clicks in her knee and I reproduce her pain.
You have to have both?
What?
Can you have one without the other, or do you have to have both?
Well, if I get the pop but no pain, it's an asymptomatic meniscus tear. It doesn't help me at all. Like I didn't find her pain. Which you would get on me.
Would you still send them for imaging at that point?
Well, if that's what she was coming in for, I mean, it's asymptomatic, so it's not her problem. So it's a question of, did I find what it is or not? What really makes me happy is if I reproduce her pain.
Awesome.
Yeah, so that's the thing. If I'm trying to find musculoskeletal pain symptoms, I have to find it. I have to reproduce it. I have to manipulate it somehow. Otherwise, it could be something else. It could be referred from somewhere else. So although we're in a profession to help people, you hurt people, which kind of explains why PT has an acronym. Okay, so let's see. I had a patient say, does PT stand for pain and torture? I'm like, no. It stands for helping you get better. That makes sense. Okay. All right, so let's see you do that. This one is not super awesome, so don't do it 100 times. So step one, flex the knee fully wherever it ends up. Step two, rotate the tibia. External for medial meniscus, internal for lateral meniscus. So flex the knee, rotate the tibia, push the tibia into the femur, and then
Then you're doing one of these as you're watching. You want to be on a safe station.
I think that's what it is. That's what she's doing, right?
tibia, medial meniscus, internal rotation of the tibia, lateral meniscus.
Go side to side.
Okay, so that is the knee.
Yours doesn't do that.
Now you've got an ankle foot. Oh, we didn't do two things. So the last thing that we have with knee is test the muscle. So the two muscles we have are quads and hams. So I can test the strength of the quadriceps by saying, okay, I want you to try to extend your knee, just try to straighten it out. And then I can test the strength of the hamstrings by asking her to bend it. So go ahead and try to bend, 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 bend. And she's really strong. So she gets 5 because she overpowered me. So I can test the quads and I can test the hams. These are super powerful muscles. So to help us out in life, we will often put them in a position where we know we're stronger. So either in sitting or with the knee flexed to 90, we can test here too. So hold, try to straighten that knee, don't let me, straighten the knee, lift the foot up, lift the foot up. And then hold, and then I get a little bit better advantage here. And then if she wants to keep going, I'll just let go and let her keep going. And then we'll let him bend, so push down. And then if she wants to keep going, I can let her. But I test the hamstrings by testing knee flexion, and I test the quads by resisting knee extension. You could also do it in sitting, before you lay them down, or at the end. Go ahead and try to straighten that knee. Now here I can really just block it and just see how strong she is, and then try to bend that knee. And I can test here too. But I can test, I'm just testing how strong is the quad? Can you extend the knee against resistance? How strong is the hamstring? Can you flex the knee against resistance? So that's my muscle test. Hamstring is flexion, quads are extension. You can strain a quad. It will hurt again, muscles hurt to stretch, and then they hurt to contract. So if it's a quad strain, it'll hurt to bend it, and then it'll hurt when you contract the quad. Okay, ankle foot. Again, I look for 1, willingness to load it, and then 2, I want to look for signs of swelling and or trauma. I should be able to see a medial malleolus. I should be able to see a lateral malleolus. I want to touch the malleoli. They should not be tender to touch. If they are tender to touch, a Weber fracture is a real deal. You can break these bones pretty easily. So sometimes I can see that it doesn't line up right. We've seen that on TV where you're like, ooh, that just made me throw up in my mouth because that looks really gross. So if I suspect a fracture on a bone, my best, and it's a superficial bone, meaning I can palpate it, my best strategy is to take a tuning fork, strike the tuning fork, place that on the bone, and the vibration from the tuning fork increases their pain symptom, then I know that it wasn't from anything other than vibration, it's bone. And I'm concerned about fracture, and I'm not going to make them do a whole lot more. Because I can separate things, break more things, that's bad. So anytime you suspect a fracture anywhere that you can get to the bone, a tuning fork with vibratory testing is your best, it's awesome. It's a good thing. You can also test for sound resonance with a tuning fork, but it's good to test bone fracture. If it hurts and it increases more than 2 pain levels, that's meaningful. I can also just touch them and squeeze them, and if that hurts, they punch me in the face. That's also meaningful. Okay. All right. Then with the ankle foot, I can ask her. So I'm looking for any signs of swelling. This thing swells up. If they aren't willing to load it, I'm concerned about fracture, so I have to test for that. The bones that are more common to fracture are the tibia, high energy, fibula, ankle sprains, and then the talus is right underneath there, and it can be very tender to touch. So I can touch the talus. The calcaneus can also fracture, so I can squeeze it. So I can touch all of those bones. Then, after I look, what do? Ask her to move. So the movements here are dorsiflexion. Can you lift your toes up? We already tested this with spine, kind of, right? Plantar flexion, can you point your toes down? We also have inversion, can you turn your toes in? And eversion, can you turn your toe out? So with a ankle injury, inversion, turning the toes in, puts stress on all the lateral structures. And you can see it because it looks like it stretches it. Eversion, turning the toes out, puts stress on all the medial structures. So if that hurts, it tells me where that pain is coming from. A lateral ankle sprain, it will hurt to turn the foot in. I also have muscles that can tear here, so I have to be careful of that. So my peroneals can tear, and my posterior talus can tear, so I can muscle test all of those. So again, I'm in the wrong position. I would really want to face her so I could see her face, but you can't see what I'm doing. And I'll just put it up here. I wouldn't test like this either because, you know, that's not nice. I'd let her rest her leg. But I can have her pull her foot up. See how much she's willing to go. She should get past 90 degrees here. I want her to point her toe. 40 to 60 degrees of this is normal. If that thing is swollen, it doesn't get that far. So their movement is very small. So that points to pain inside the joint. And I can test the muscle, so try to lift your foot up. Push, 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 push. Good. Push down. Okay, try to turn your foot in. That's testing inversion. Try to turn your foot out. That's testing eversion. So I can test all of those muscles. Is there anything we left out on that list? We did clonus? Yes. Okay, pulses are critical here also. So you've got to be able to palpate your dorsal pedal pulse, which is on the dorsum. You know where that's at? And your tib pulse, and then refill. So you got that. So ankles are pretty straightforward. Typically, we can see the swelling. We can see a loss of motion. Our big thing are the bones tender to palpation? Does it hurt with vibration? Do I need an x-ray? Questions on that? Okay.
Excuse me. What you said about the joint fork, so this is like a fracture, so what are we expecting?
Pain. So the question is tuning fork. Tuning fork is not a compressive. I'm not hitting any soft tissue. So if I strike the tuning fork and I place it on the bony prominence, and that increases her pain more than 2 levels, it's not just hypersensitivity to me touching, it's the vibration through a broken, cracked bone that's causing the pain. So it's an excellent screen for fracture. We use it on fingers, everything. All right. We only have arms left and a neck. Okay, you ready for neck? So let's go back to spine.
Real quick, you mentioned the way he was saying it, he has twice, no, or he disagreed, and he said that was comparing to talk about later. Is that because it is?
Hips.
Hips.
Good. Yeah, he's externally rotating his hip. Okay, the other thing about foot, how many of you have had plantar fasciitis? It's terrible. So where is your pain? On the bottom. So I can stretch the plantar fascia through extension of the big toe. So if I extend the big toe and that increases their pain, that makes sense that it's plantar fascia. And then the other big common problem is an Achilles tendon rupture. They will tell you it feels like someone shot them in the back of the leg and they heard a pop. And then if you squeeze the calf, the tension in the calf causes automatic plantar flexion. So you can squeeze your own calf and test it. So if you squeeze the calf and you don't get that auto plantar flexion moment, that tendon is gone. It's not there. Okay? So that's a nice one too. It's very quick. Easy to do. You don't miss that one either because you can't see the tendon. You can't find the tendon. They were shot. They won't come up on their toes. So they won't go. Okay. All right, cervical spine. I'm looking for alignment of head on neck. If they come in like this, they're avoiding something, right? Most of the time, these patients have had some sort of trauma or whiplash type of injury, or they're complaining of symptoms down into their arm. If they are complaining of symptoms down into their arm, it is not different than in the lumbar spine when they're complaining of symptoms down into their leg. So if they are complaining of symptoms down into their arm, it's going to be what type of tissue that I'm thinking of? Nerve. And where the leg I have 2, and the arm I have 3 nerves that I have to think about. So when they come in and they complain of neck pain, I'm looking for signs that the muscles are really tight. I'm looking for signs of bruising and swelling. And then after I look, what do? It's the same rules. Okay, I ask them to move. So I ask them to move. The neck moves almost like the L spine. So I have flexion, extension, side bending, and rotation. And I'm looking for symmetry. And do I reproduce their pain with that? So flexion, I have quite a bit of flexion. Most patients do. So if they are not willing to look down to where their eyeballs get to the ground, that is a limitation of motion. Extension, we have a lot of extension. So if they're not willing to look up and this is their extension, you say look up at the ceiling and they go like this. You're like, oh, okay. They're not willing to move their head. So then I know that there's a loss of extension. One thing that I'm really cautious of is rotation. So if they are not willing to turn their head more than 45 degrees, that is a sign that they could have sublux C1, C2. And I want to be really careful. I don't ever turn someone's head for them. I let them turn their head and let me know how willing they are to move. I wait until they're safe. If they have problems, the red flags are they're complaining of dizziness, drop attacks, difficulty swallowing, like these all make sense, right? It's all cranial nerve signs. They are hoarse, we call that dysarthria, or they're seeing double, or we just see nystagmus in their eyes. That's always bad, right? Nystagmus is bad. So we use those indicators. So if they come in, I will always ask, do you have dizziness? Have you lost consciousness? Do you lose or have changes in your vision? Are you having difficulty swallowing? And I listen to the quality of their voice. And if I get positives in those, I absolutely don't touch their head because those are cranial nerve signs, which means something's going on to blood supply to the head, to the brain. And so we're very cautious. If they're not willing to turn their head more than 45 degrees, the culprit could be C1, C2. And that's very concerning. And X-ray is safer than me trying to turn their head. Okay, so if I reproduce their pain with movement, then I'm pretty good. I know it's coming from the neck. And if the pain goes into the arm, you have one provocative maneuver. And that provocative maneuver is called Sperling's. And it is a classic test. Before I get to Sperling's, I can still screen motor units and reflexes here. So just like the leg, I have C5 is a huge motor unit. What's my reflex for C5? Biceps and brachioradialis, so C5, C6. I've got overlap there. And then C7, triceps. I have sensory testing, and then I have testing of upper extremity. So I can test for shoulder strength for C5, C6, and I can test for grip strength. It gives me an indication of a little bit of 6 and then T1. So I can just have them squeeze my hand too. Grip strength, motor unit strength testing. My provocative maneuver that is new that we won't cover with other things is called Sperling's. So Sperling's is the combination of extension and rotation to the side. Now I'm going to be very teenage drama queen again. Extension and rotation to the side will also occlude the vertebral artery. So if your patient starts to not make any sense or their whole face goes flaccid, maybe don't do the rest of the test, okay? Because you are occluding an artery. And I know you know that. I just have to say that to my students like really dramatically because sometimes they forget and just want to go straight to the test. Okay, so this test, extension and rotation, I am closing and narrowing the foramen, the vertebral foramen. So this will compress a nerve in the neck. So if I do this and it reproduces pain down their arm, then it's coming from a pinched area in the neck. Sometimes that's not enough, so I may have to apply a little bit of overpressure with that just to make sure that I compress the nerve. But I didn't slam his head into the ground. It's just a little gentle overpressure. So I do this very small. I first watch them move and see how they move if they're willing to move. That's safe. Then I have them go into extension and then I add rotation and I kind of wait. If that's really, really painful, it also points to the joint. I know it's in the neck. I'm asking, am I reproducing your arm pain? If I reproduce my their arm pain, that counts as a positive Sterling's. I actually don't have to push on their head. I've already got it. But if I don't get it, I can come in, add a little bit of overpressure just to make sure that it's negative. This is a pretty sensitive test for radiculopathy coming from the cervical spine. So it's a nice test. It's in everything. So it's a great provocative maneuver to know if you're trying to figure out if that pain, that numbness and tingling in their arm is carpal tunnel or neck. Okay, so they could also come in complaining of pain here. So let's move in your hand out to the shoulder. So shoulder, I'm always going to screen the neck first because things that cause problems in the shoulder can come from the neck because that can be a referred spot. So with shoulder, I want to make sure that I look. And what do I look for? I look symmetry. So where's the scapula? Where's the humerus? How are they holding it? Where's the clavicle? So if they come in and their clavicle's up here, they dislocated their AC joint or broke their clavicle. So I mean that's okay, I got that. All right. So I look for that. I look for symmetry side to side. So I will palpate their SC joint. Palpate your SC joint. I can find the proximal end of the clavicle where it attaches to the manubrium. I actually had a patient who dislocated this on a bus accident and it really was out here. That's kind of weird. I'm like, oh yeah, you sure did. I don't have to test that at all. I can see it. Okay, then you can come and find the AC joint. So the distal end of the clavicle right here. It should be nice and flat. If there is a step off, something's wrong. It's separated, it dislocated. They're not going to move their arm very much for you. Then you come and find the humeral head and the acromion. They should be in line. If that humeral head, if there's space between there, then that's a lax shoulder. It might be dislocated. Be careful touching that one, right? This should all be connected. Okay, the next thing that we do once we look, we'll also look at the scapula. The spine of the scapula should not be super prominent. So if I see a fossa or a hole on the top of the spine of the scapula, that could be an old rotator cuff tear. So I just have to know that. Okay, so I look at that. I look at its position. It should be symmetrical. After I look, I make a move. So which directions am I going to move the shoulder? Up, down, up, down, in, out. So can they flex? Can they abduct? Can they internally rotate? Can they externally rotate? And are they willing to do that? If they have torn their rotator cuff, they won't make it all the way up. And they will do what's called a shrug sign. So what will happen, and they won't make it all the way up, so I don't know why I went all the way up. But what will happen is their muscle's not strong enough. Supraspinatus is usually the one that tears. It initiates this movement. So they can't initiate the movement, so they shrug to let their deltoid help. So a shrug sign, I'm making it dramatic, but a shrug sign where the shoulder girdle lifts before the arm should make you think something's wrong, and it's either really tight, adhesive capsulitis, frozen shoulder, or it's really weak. So if they can't get their arm all the way up, what do we do? Because most patients who come in with shoulder problems, this is what they do. Ow! Right right? It hurts. Okay, so if they can't do it, I have to see. I need to check. So how willing are they to let me do it? Let me see. Most of the time, they're not going to let you go much past 90 either. You just have to be aware of that. No, you're not getting them up to their ear most of the time. But you get a sense of, is it really weak, or are they just not willing to do it? And if they're not willing to do it, they will guard, they will fight. And so we call that an empty infield. If it is true weakness, you can take them out here and just see if they can hold it. And if they can't and their arm drops and they had a shrug sign, think rotator cuff. Okay, so then I want to test the muscles. So to test the muscles, I will just push the arm. I've got to test flexors, abductors, extensors, adductors, internal and external rotators. That sounds like a lot, but it's really easy. So I'm going to have you stand up. All right, so I'm going to push. You tell me what I'm testing. So hold your arm right here. Don't let me push it back. Shoulder. If I let go, he goes up. So shoulder, flexors. Okay, keep it right here. Don't let me push it forward. Extensors. Don't let me push it towards your body. Abductors. Don't let me pull it away from your body. Adductors. Okay, hold right here. Don't let me push your wrist towards your belly. External rotators, away from the belly is external, so don't let me push it in. He's trying to push it away. Okay, don't let me pull it out. Internal rotators, he's trying to pull it in. So his arm doesn't move. I just test the muscles. And if I reproduce his pain, it's a muscle problem in the shoulder, or it's a shoulder problem. You have one provocative test for the shoulder. What's it? Empty can. So empty can is a long lever stress test for the supraspinatus, which is the most commonly torn tendon. So this thumb up is a full can. Hold, don't let me push down. Thumb down, hold, don't let me push down. This is the empty can part. So if this hurts more than this, I put more stress on the supraspinatus. Now if that thing is torn, he can't do this if it's completely torn. Because remember, his arm would just drop. So this is testing for pain from the muscle that's relatively primarily intact. So full can, hold. Empty can, hold. And I see if it provokes pain. It's not a muscle test for strength, it's a test for pain. These are muscle tests for strength. Hold, don't let me push. Hold, don't let me push. I'm also testing for pain though. Deltoid, usually not painful. Supraspinatus is an abductor. So if I say don't let me push towards your body and he says ow, 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 that's supraspinatus right there, resisted abduction. It should match this one right here, empty can. Both of them tell me the exact same thing. If he tore rotator cuff and it's a bigger tear, he will be really weak and painful in external rotation. If he tore subscap, he will be really weak in internal rotation. I can move to the elbow. I look at the elbow. I look for signs of swelling. Most of the time it's a dislocation and it dislocates posteriorly. So I want to make sure I can see the olecranon and find the olecranon. If I can't, that's really swollen. The elbow flexes and extends. What muscles flex? Biceps. And he's got one. Look, I can watch his biceps. All right, biceps often tears. So a tear in the biceps, he will be weak in flexion, and I will see a defect here. You can actually see biceps tears. They look pretty gross, actually. Okay. And then I resist flexion hold. so I can get a sense of how strong is it compared to the other side. And then you can push down, extension. At the elbow, we also pronate and supinate. So pronation and supination. This will tell me about the radius and the ulna, both proximal and distal. So I'm looking at their willingness to move. And then I can test the strength of it. Don't let me turn you up. So he's trying to turn down, that's pronation. Don't let me turn you down. He's trying to turn up, that's supination. If those are painful, it could be a supinator problem or a pronator problem. So anytime a muscle hurts, or there's a problem with the muscle, it hurts to contract it, and it hurts to stretch it. Okay, then we can move to the wrist. There is a problem at the elbow, lateral epicondylitis. Anybody heard of that? Tennis elbow. So tennis elbow is my wrist extensors. It's on this outside. So they're gonna hurt to palpate that lateral epicondyle. Find your lateral epicondyle. I have no muscle, so mine just pokes right out. But can you find your lateral epicondyle? So that is often where it hurts. Okay, so come down just a little bit, extend your wrist. You feel those muscles working when you extend your wrist? So it's your wrist extensors that come from there. So if you have tennis elbow, it's gonna hurt to extend your wrist because you're contracting the muscle, and it'll hurt to stretch your wrist, flex it because you're stretching the muscle. So to test that, I just test the wrist extension. Hold, don't let me push down. And if that reproduces his pain, I'm like, oh, that's good. Now, some of you play golf, so you get golfer's elbow. That's on the other side. So I can resist flexion, hold, don't let me pull down. And then I am testing for the medial side. So I palpate those epicondyles. The wrist muscles come from the elbow. Now I'm going to work my way down to the wrist. So I can have dislocations and fractures at the wrist. The most commonly fractured wrist bone is the scaphoid. You find the scaphoid where? Did y'all learn that anatomy? Anatomical snuff box. So I can come in and I just put my thumb right in the base of their thumb. That's where the scaphoid is. If that is really tender, that could be a scaphoid fracture. So that snuff box right there, if they fell on their hand, I'm like, uh-oh, I want to test the scaphoid. I can also just test movement of the carpals to see if it reproduces pain by having him actively flex his wrist and actively extending his wrist. So that is carpal motion. And then I can also have him radially deviate, so move towards his thumb, and ulnarly deviate, move towards his pinky. And I'm just supporting his hand because the hand often hurts, so we just are gentle when we get to the hand. We're hand-holding people at that point, right? So we're just supporting them. So if it's wrist pain, it will hurt when we move it. It hurts to flex, it hurts to extend. It will hurt to radially deviate, or it'll hurt to ulnarly deviate. I'm really concerned about the scaphoid, so I am really concerned about thumb-sided pain. That scares me, that's image-worthy. And then I can actually have them move their thumb. So thumb up, thumb down, thumb in, thumb out. If moving the thumb hurts worse than moving the wrist, then I may have to go to the thumb joint as a problem. And then we can always test grip strength. And then you have one, oh, you're very strong. I'm using my fingers, thank you. We have one provocative maneuver for the nerve. So we have one big giant nerve that can get compressed here, carpal tunnel. So I can come and tap it and see if that makes them get numbness and tingling. I will look and just make sure I don't see any signs of atrophy in the hand. So if I have carpal tunnel, the median nerve innervates what part of my hand? The pinky side or the thumb side? The thumb side. So I'm going to see atrophy on the thumb side. So if I see a loss of this thenar mass or weakness and gripping around the thumb, then I'm going to be concerned about carpal tunnel. Also, they're just going to complain of numbness and tingling here. If they complain of numbness and tingling here, which nerve is that? Ulnar nerve. Ulnar nerve can also get impinged at the wrist. It's just over here on the outside around the hamate. So I can tenel it over here. So if this causes tingling, that's ulnar. If this causes tingling, that's median. Some of you, your students, you're studying all the time, right? All the time. Because your instructors are in the room, like you study day and night. Yes. Okay. So you will get a lot of thoracic outlet and tingling in your hands. And you may wake up with tingling in here. Yeah, we can talk about that later. But that's where you're trapping that ulnar nerve. Okay, so if I want to confirm, I can tap the nerves, but there's also a test called Phalen's. So with Phalen's, this nerve gets stretched with wrist extension, and it gets compressed with wrist flexion. So Phalen's is flexion, compression of the nerve. It would work better if they spelled it with an F, but they spell it with a P, so I'm sorry. But this is Phalen's. So we'll ask them to flex their wrists, or we don't have to be that mean. We'll ask them to flex their wrists and see if we can reproduce numbness and tingling in their fingers, thumb side, and that confirms that the compression is happening in the carpus, not in the neck. But it could have come from the neck, and how would we find it in the neck? Spurlings. Yay! Woo! Yeah?
Yeah.
You got all that in your head? Awesome. Okay, all right, check your list and make sure we didn't leave something out.
All right.
Wow.
Okay. So fingers. All right, so you have resist finger abduction and resist finger adduction. And you also have touch each finger to their thumb. So when you're testing wrist and hand movements, we can also test integrity and movement of fingers. So I can test grip strength. That's a great measure of strength, but not necessarily a great measure of mobility. Testing the ability to touch each finger to the thumb will test mobility. Do you see how many joints I have to move to get there? So this is a nice screen. If they can't, it doesn't tell you exactly where the problem is, but it tells you there's a problem because they should be able to get there. And so then you can refer where you need to refer them to. You've identified the problem. And then testing finger abduction, that's spread your fingers apart. And don't let me push them together. So hold. If you really want to be mean, do the pinky, hold, because they never can. Right? Okay. So that's adduction. That is testing ulnar nerve strength. So know who you're testing, why you're testing it. And we will almost always pick that pinky because that's the side that we know it innervates. So I'll take the pinky and say hold, don't let me push. But I can test them all. Don't let me push those fingers together, don't let me push those fingers together, thumb's different. Okay, now that's testing abduction. I can also test adduction, and I can say, now I want you to, whoops, he's already there. Go ahead and open back. Okay, can you squeeze? Good. Can you squeeze? And I can try to push it away. The middle finger, it won't move, so I have to test the fingers on the opposite side of it. So I'll test this one, try to bring it in, try to bring it in, try to bring it in. And I can test this one, try to bring it in, try to bring it in, try to bring it in. So I can test finger movement. Good. Okay, keep checking your list, make sure you got everything.
Does it mean anything like that? You know, people tell you that. Does that mean anything people can't do that?
Oh, the dissociation? No, it means they make really less Star Trek, which I can't do. Like, I can't do that. I don't know. It just means they have good dexterity. But yeah, it's a party trick, not an interpretation trick.
What are the, on the hands, it says
So that are these joints.
oh, so you're just
Yep.
distal.
So MCP is the knuckle. And then IPs are the fingers proper. Okay, so I have 3 daughters, just for fun, I'm gonna tell you this. And they injure, like I've had to become a hand therapist based on volleyball and basketball, and oh my goodness, I cut my finger with a knife injuries. And so these joints are very commonly injured with jammed fingers. And so in patients that come in and they have a finger injury, we're trying to figure out 2 things. Did they tear a tendon, which is really bad, and I'm not touching their hand, I'm sending them off, because the farther those things get apart, the worse it is for the surgeon. Or did they jam a joint? So a jammed joint, the tendon is all about the muscle doing it. And then a jammed joint, I can tell also when I do it, so passively. So with my kids, when they come in and they're doing crazy stuff, I'll just come in and just see how irritated is that joint. Did they jam that finger? And it's always the joint that's swollen. It always hurts laterally. So that when you check joint movement, we're checking it when we do this. When we go okay to each finger, I have to move and flex at my MCP, my PIP, and my DIP. But if they can't get there, then I can come in and move each one of them. Is it the MCP, the PIP, or the DIP? Which that one's a little tight right there. That's okay.
I think so.
Yeah, it works a little. Your muscle was a little tight right there. So let's just give it some more space.
Somebody's so small.
We said muscle. You got it.
It's so small.
All right. Anything else on there? Do you feel like you can evaluate this? All right. So move, contract. If you reproduce the symptoms with movement, you are happier that it's a musculoskeletal problem. If it's a muscle, it hurts to contract and stretch. The knee was the joint where you had all of those tests, but it's because you see a lot of them acutely. And if they say pop, you think ACL. If they say I got shot in the back of the leg, you think Achilles. If the pain radiates, well, they could have actually not shot there. Past the knee, nerve. Into the arm, nerve. All right, good job.